Hello, hello. Check, check, check. check, check, mic check, hello, check. Hello. Hello, hello, check, hello, check.
welcome all the delegates, speakers, and moderators on this Sunday morning. Thank you for coming early and supporting us. So we will straight away start the sessions. So I'll hand over to Dr. Aravind will guide in the sessions moderating. Okay. Thank you. Enjoy the learning.
Good morning, everyone. A warm welcome to all of you. On behalf of Indian Society of Vascular and Interventional Radiology, Salem Chapter and Salem Gastro Club, it's my pleasure to welcome you all for today's CME program, Multidisciplinary Management of Portal Hypertension. This is also the quarterly meeting of Tnpy Isvir. So we have with us outstanding faculty of interventional radiologists, medical and surgical gastroenterologists, and also hepatologists from across Tamil Nadu and beyond, who will be sharing their expertise with us throughout the day. Uh, to start off without much ado, to start off with the first session, may I now request the speaker, Dr. B. Sivasubramaniam, Assistant Professor of Medical Gastroenterology, to come over. This will be on medical management of portal hypertension. May I now request the moderators to come over to the stage. Dr. Jason James, Assistant Professor, MG Salem, Government Mohan Kumar Mangala Medical College, Salem. Dr. Jason. Dr. Ramamurthy, Surgical Gastroenterology, Assistant Professor, GMKMC Salem. I think sir has not yet come. Dr. Prabhakaran, Consultant Interventional Radiologist from Erode. Dr. Sugumaran, Consultant Medical Gastroenterologist from Dharmaburi. I think Dr. Ramamurthy and Sugumaran are not here. Anyhow, we will start. Dr. Ramamurthy has come. Sir, please come over to the stage, sir. Over to you, Dr. Sivasubramaniam.
Good morning. Good morning, everyone. I'm the opening batsman of the day. I'm going to briefly discuss management of portal hypertension. Before that, I would like to thank Dr. Santosh for inviting me as a faculty to deliver the lecture. So, before going topic in detail, this is anatomy of the portal vein. So, portal vein is formed by the formation of the joining of supramesenteric vein and splenic vein, and drains into the liver. And these are the goes to the sinusoid. The sinusoid plays a major role in causing portal hypertension. And portal hypertension defined as increase in portal pressure gradient above 5 mm mercury. And most common cause is cirrhosis, and less than 10% can be due to non-cirrhotic causes. These are various causes of portal hypertension at different levels. And what is the pathophysiology behind portal hypertension? There is increased resistance to portal blood flow, and splanchnic vasodilation, increase in portal blood flow. And these are the main targets in our treatment also. How to evaluate the portal hypertension? There are two methods. Direct methods is invasive method, which we are not performing now, and the indirect method is frequently used to measure the portal hypertension. So indirect portal pressure measurement uses the HVPG. This is the most common method to measure. That is the difference between the wedged hepatic venous pressure and the free hepatic venous pressure, and which is accurate in detecting only sinusoidal and post-sinusoidal portal hypertension. Not effective for detecting pre-sinusoidal cause such as portal vein thrombosis. This is a score which we see with the HVG measurement from 1 to 20. It is more than 10, it is called clinically significant portal hypertension. It is more than 12, there is a risk of fracture of varices. And more than 20, even we treat with any modality for acute variceal bleed treatment by failure and mortality eventuous. And this is another chart which is showing the use of HVPG in different diagnosis of portal hypertension. As I said, in pre-hepatic and pre-sinusoidal, there is no use. The pressure will be normal. And in sinusoidal portion, it is increased. In heart failure, both are increased, so the HVPG will be normal, even though there is a portal hypertension. In Bhattacharya, you cannot perform portal HVPG because of the thrombosis. So, what are the non-invasive assessment? So, imaging techniques such as ultrasonic Doppler are the first line investigation for diagnosing portal hypertension. And we can see splenomegaly presence of portal collaterals, ascites, and diameter of the portal vein, which is more than 12 to 13 millimeter, which can be diagnosed with portal hypertension. And in addition, we can look the morphology of the liver and patterns of the portal vein also with the ultrasound and Doppler. CT MRI with contrast plays in the same role. And elastography is the another important evolving. It's an established method to diagnose liver stiffness. And nowadays we see spleen stiffness also with elastography. And the cirrhosis is associated with increased LSM and SSM. And many other studies showed good correlation with the hepatic venous pressure gradient. So in Balino 7 recommendation, which is published in 2022, they said to measure to diagnose the portal hypertension, the gold standard is HVPG. The clinically significant portal hypertension is seen and are diagnosed when the HVPG is more than 10 millimeter mercury. So non-invasive other tools for portal hypertension, the transient elastography is recommended, and liver stiffness measurement less than 15 plus platelet count more than 150 rules out the clinical significant portal hypertension. So why this is being developed in Western countries? Because in our country, doing endoscopy is an easy job rather than measuring this HVPG. So in there, the endoscopy cost is more, probably because of that have come with these measurements. So and SSM also used to rule out clinically significant portal hypertension. If the measurement is less than 21, the portal hypertension is ruled out. So management, I am going to discuss about medical management and endoscopy and further management by my colleagues. So before going to medical management, so these two things are needed: the increased hepatic resistance and increased portal flow. So these two to be addressed to treat the portal hypertension. So to decrease the portal blood flow, we have got non-selective beta blockers, somatostatin analogs, and vasopressin, and terlipressin. These somatostatin and vasopressin, terlipressin are used in acute variceal bleed. It is not used to prevent in prophylaxis. So drugs that decrease intrahepatic resistance, we use ARBs and alpha-1 adrenergic blocking agent like prazosin and nitrates. So coming to NSBBs, we commonly used propranolol and adderall. And since 1981, this has been used as a treatment for decreasing the portal hypertension. And mechanism we all know is a blockade of beta 1 and beta 2 adrenergic receptors, which leads to decrease in cardiac output and decreased portal blood flow. And dosages for nadolol, we give once a day dose, starting with 20 mg. Maximum it can go up to 160 milligram per day, but it is not being used widely. Propranolol is the one which is used widely, and maximum dose is 320. I never been used 320, only up to 40 mg BD I have used. Why? Because there is patients may have reduced systolic blood pressure less than 100 and heart rate may come down in our individuals. So 320 per minute I have never used. And how to assess the effect of beta blockers? So monitoring the HCPG in our part of the world country, the HCPG measurement is very costlier than doing endoscopy. So HCPG measurement is done in other countries to measure to assess the portal hypertensive effect of the portal hypertensive with the beta blockers. If it is less than 12 millimeter mercury, there is significant reduction in portal pressure they have documented. But in our country, we use clinical response. Target heart rate should be less 55 to 60 beats, or there should be a 25% reduction in the baseline heart rate. Side effects, so there are very few. Lightheadedness, fatigue, shortness of breath are reported. And contraindication we should not use with the cardiac events. And what is the use of carvedilol in preventing portal hypertension? It's just got dual action alpha and beta adrenergic blocking property. And nowadays, recently, when I found articles to any recent update regarding the management of portal hypertension medically, there's only one update, carvedilol they started to use when there is clinically suspect clinically significant portal hypertension. they suggested and they have shown that which retards the disease progression and decomposition also is delayed by using carvedilol. So again, this decreases the portal flow, reduce increased intrahepatic vascular resistance. Maximum dose is 25 milligram per day. The Predisi trial, which showed usefulness of this carvedilol in preventing the decompensation of cirrhosis in CSPH. Nitrates, they are no longer recommended now. This is causing more damage than benefit. Vasopressin analogs. So vasopressin is a potent splanchnic vasoconstrictor, but it has got potent systemic side effects like bradycardia and decrease in cardiac output due to negative inotropic and chronotropic effect. So now the analogs were used like teleprasin. It's a semi-synthetic analog of vasopressin. We have to get a written consent before giving a teleprasin due to the following adverse events. Myocardial ischemia is seen in 3 patients. Immediately they developed myocardial ischemia after giving, and they managed with subsequent management for ischemia, and mesenteric ischemia seen in 2-3 patients. And respiratory failure and hypoxia might worsen after using this telepressin. So should get a written consent stating all these complications may worsen. And the maximum dosage in GA bleed we give 2 milligram 4th hourly for 7 to 8 hours. And then we can reduce to 1 mg. It's used in HRS-AK also. And somatostatin again used in acute varicose bleed. It's a very short half-life, so it's useful in acute varicose bleeding. You can give bolus of 250 followed by infusion with the 250 milligram per microgram per hour. Sorry, milligrams per microgram. And octrade again it's a very commonly used drug in treating acute varicose bleed. 100 micrograms stat followed by 50 mg per hour for maximum 5 days. We can use these drugs. So what are drugs that can decrease the intrahepatic vascular resistance? We have alpha-1 adrenergic blocking drugs like prazosin, but long-term usage of this prazosin can lead to again increase in portal hypertension and sodium retention as it is. So it's not routinely used. And angiotensin 2 receptor antagonists such as losartan and irbesartan also no documented benefit reduction in portal hypertension. So what are newer targets? Any new drugs available? So regarding the new drugs, all under the evaluation under trials, so none of the drugs have come into market. So in statin, among these statin, simvastatin, it is having recent studies to show any documented value in treating portal hypertension, and other drugs such as anticoagulants, anti-angiogenics are under evaluation and trials. So briefly about statin, simvastatin 40 mg per day can increase the intrahepatic nitric acid availability, which decreases endothelial dysfunction, and stellate cells which are quiescent and activated can be reversed in cirrhotic liver, they say. So associated with a modest but significant decrease in HEPG without any effect on mean arterial pressure. So this comes to my end of my presentation. Any take-home message? So from my point of view, there is no much drugs are developed to prevent portal hypertension or decrease portal hypertension. Only development or carvedilol can be used earlier to prevent the decompensation in cirrhotic liver, and which may retard the portal hypertension progression. And simvastatin can be used, but once again the patient should have a normal LFT. SGOT should be within normal limits to start this drug. And any other drugs needs to be developed. Thank you. Any questions?
The floor is open for discussion.
Okay. There are no more questions. Thank you.
No,
one started on beta blocker or non-selective beta blockers, in a patient with decompensated cirrhosis, when will you consider reducing the dose of beta blocker, or you will continue with the same dose, sir?
So when we achieve the target heart rate, we can reduce the dosage. If it further reduces, then we have to stop, no other way. And other things in any recurrent encephalopathy or HRS, we have to reduce the dosage or we have to stop the drug. Or in documented side effects, we have to stop.
Yes, sir. Okay, thank you, sir.
In addition to beta blockers, can we use simvastatin as an add-on drug routinely, sir?
It's documented, we can use. The LFT is normal, but need some more studies also establish the evidence.
Thank you, sir. Thank you so much. We request the moderators to stay back on the stage while we move on to the next topic within the same session. It is endoscopic management of esophageal varices by Dr. Karthikeyan, HOD, Medical Gastroenterology, GMKMC. Over to you, sir.
Hello. Just small announcement for the residents who have registered for the workshop. So we have split it in your batches. So those who are registered for a particular batch in a particular time can make use of the workshop. It will be open up to 11 a.m. So kindly rotate yourself and make use of it. Thank you.
Good morning. Good morning to all. First of all, before starting my talk, I would like to thank all my radiology colleagues who are helping us in both diagnosis and all interventions whenever we face difficulty. Thank you all from all hospitals. So the topic given to me is endoscopic management of esophageal varices. The other topics will be covered by, like the gastric varices will be covered by Dr. Rajesh. So the gold standard for diagnosis of esophageal varices of any bleed, we have to proceed with the upper GI scopy. There is a role for US evaluation of the collateral circulation, prediction of recurrence, and US guided treatment of gastric varices. US has this recently evaluated and emerging tool for a coil and a glue therapy in case of any gastric varices bleed. So coming to the first and foremost, the classification of esophageal varices is more important because the intervention depends on this. It can be classified by modified packet classification, grade 1, 2, and 3. There is the varices extending just above the mucosal level, and grade 2 is varices obliterating 1/3 of the esophageal lumen that cannot be compressed by air insufflation. And grade 3 is varices projecting up to 50% of the occupying the luminal diameter and in contact with each other. This classification is commonly followed by medical gastroenterologists. Usually hepatologists follow classification like small and large varices for them for easy remembrance. So anything above grade 2, they call it as a large varix and with RCS. So the classification of esophageal varices according to the Japanese Research Society for Portal Hypertension based on the characteristics of the varices, the form, the fundamental color, the RCS, red color signs, and the location of the varix and the esophagitis. Based on the form, it can be graded as F1, F2, F3, whether it is a straight column or slightly tortuous or a large size varix. And based on the color, whether it is having a white color or blue color, and RCS, which is more important. So in any research, even with the grade 2 varix, to have RCS, we have to proceed with the endoscopic variceal ligation. The types of RCS are the red vein marks, cherry red spots, hemocystic spots, and the fibrin plaque and diffuse redness. And based on the location, it can be classified as superior, medialis, and inferiors. Coming to these are the RCS, they are shown in pictorial representation. The first one is the cherry red spots. You can see the column due to the dilatation, and the red veil signs, the vascular torches. Within the vessels, you can see the vascular markings and the hemocystic spots, almost like a filled cystic lesion within the varix. So esophageal variceal hemorrhage is confirmed or inferred by active bleeding, either a spurt or a ooze. Active bleed, signs of recent hemorrhage, presence of a nipple sign or a fibrin plaque or indirect interference, blood present in the stomach with no identifiable source, we have to expect a varices, because in most instances, patient presenting with a massive UJ bleed, we proceed with the upper GI scopy, the column will be compressed and we will be confused whether the patient has bled from the varices or some other lesions are present in the stomach. Point to so these are the signs I told. These are the fibrin plug. It's a platelet plug. The varices are bled and it is occluded by a fibrin plug. And yes, you can see active use. So coming to the how will you proceed with any patient with UJ bleed? First and foremost, we are doing an upper GI scopy and we have to see and assess whether there are any varices. If there are no varices, we have to repeat our endoscopy every 2 to 3 years. And if there are large esophageal varices, we have to measure the HVPG measurement. But since, as already highlighted by Suva Subramanian, it is an invasive tool because most of our patients with DCLD or ACLF all will be in coagulopathy. So it will be very risky to carry out any invasive investigation like hepatic vein pressure gradient measurement. So we have to proceed with the non-invasive tools like transient elastography. So we have to, if the pressure is elevated, you have to put them on a non-selective beta blocking agent. And if there is a varices or small varices, we have to repeat the endoscopy every 1 to 2 years, and we have to continue. Contraindications to beta adrenergic blockers are already highlighted by Dr. Subramanian. The timing of endoscopy is $1 million question. As everybody in every forum, it is asked what time you'll do an endoscopy. The endoscopy should be ideally performed in hemodynamically stable patient. First, you have to resuscitate the patient, preferably within 12 hours and at the latest within 24 hours. If the patient remains hemodynamically unstable, despite resuscitation, or is actively continuously bleeding, there is no other growth, you have to proceed with an endoscopy and do with the interventions. Very early endoscopy has not been proved, that is, the outcome has not been improved. The mortality also not improved, the trials they have conducted. So ideally, we should resuscitate the patient. And if you have got all tools in the intervention and a specialist, you can proceed with the endoscopic intervention after within 6 to 12 hours. So urgent endoscopy is in any endoscopy done less than 6 hours, and early is 6 to 12 hours, and delayed is more than 12 hours. This is the picture showing the endoscopic varicose ligation. What is the mechanism? It achieves vascular occlusion through mechanical strangulation, ischemia, ulceration, and scar formation, venous fibrosis, ultimately leading to a ulcer within a duration of 7 to 10 days. It is highly effective with immediate hemostatic. There is a bleeding control and success rate exceeding 90% for acute bleeding, reduces 30-day mortality, and improves overall survival in specific patient groups. These are the pictures showing the varicose ligation. After binding, these are the band, one of the bands, and the band will be fitted at the tip of the endoscope, and we simultaneously deploy from the esophageal gastric junction in a circumferential manner and try to obliterate all large varices. So these are primary indications by ASLD and ESL guidelines for 3 main scenarios can be classified as a primary prevention, just preventing initial bleed in high risk, moderate to severe varices, that is child B and C, or those with RCS. An emergency treatment providing immediate hemostasis for acute esophageal varicose bleeding, and a secondary prevention, that is a reducing rebleeding risk, typically paired with the non-selective beta blockers. The procedure and the follow-up. Bands are applied in, as I already told, it is starting from the OG junction, using a multi-band ligate to proceed with this. The post-EVL schedule, the every 1 to 4 weeks until the varices are completely eradicated. Ideally, because the ulcerations will take around within a week, so it is preferable to do a repeat banding and ligation after 2 weeks. Follow-up endoscopy every 3 to 6 months for the first year, and then annually. Because in our practice, commonly we are seeing many rebleed. If anything depends upon the HVPG. If the HVPG is high, the chances of rebleed is more. So the limitations of the size constraints: larger veins risk incomplete ligation and massive bleeding, smaller veins, excessive suction, pain, and scarring, and the tissue health, because multiple ligations, the tissue elasticity will have been gone, and there is an increased chance of band slipping or ulcer forming. And these are the factors affecting the outcome of the banding. And the visibility and the stability, massive blood loss can occur, surgeon's visibility. So you can overcome with this with proceeding with a cap the fitted to the tip while doing an initial endoscopy. The major risk is doing an endoscopy in upper GI bleed is the risk of aspiration. Hence, if you are not having any visualization, better to do a endotracheal intubation and proceed with upper GI scopy. And massive blood loss can occur and obscure the surgeon's visibility. Patients with severe instability or organ dysfunction or severe hemorrhage require fluid resuscitation and stabilization before the procedure. What are the complications and risk? The complications occur in 2 to 20% of the patients. Initially, immediately after banding, the patient may complain of severe retrosternal discomfort or a mild mediastinitis, which usually subsequently settle within 12 to 24 hours. We need not do any treatment for that. After, say, 6 hours, you can put them on a sucrafil and a PPA, and if they are still complaining of pain, you can give some analgesics. Usually, this settles spontaneously. And severe complications are esophageal strictures, perforations, or infections. The danger window, this is a sloughing phase where the ligation band detaches. It carries significant risk of ulcer-related bleeding, affecting 2.3 to 15% of patients, which can be fed. The other modality, when the field is not clear, whenever you are seeing a UJ bleed patient, it is full of blood or a continuous spurt is there, you are not able to identify the site of the bleed. The full column of esophagus is filled with the blood, then we have to proceed. There is no other go with the endoscopic varicose. There is a sclerotherapy, EST, strong alternative or a rescue option, but of course it carries its own complications. It is difficult due to poor carried out in the following settings. It is a poor visibility or a severe mucosal scarring, or when the varices are too large for ligation. Not recommended for primary prevention of bleeding. This table shows the sclerosants which are commonly used. The sodium tetradocoyl sulfate 1 to 3%, ethanolamine oleate 5%, sodium orvate 5%, and polydocanol 1 to 3%, and absolute alcohol 98 to 100%. If any sitting in the periphery, if you are not finding any sclerosants, you can use your dextrose. 50% dextrose can be used as a sclerosant, and we have tried in our college when I was doing my PG. So using the commonly used sclerosants of polydocanol, injected both intravarically and paravarically, forms a clot and permanently scars the vessel. And of course, the complications are, as I already told, there is a risk of strictures, mediastinitis, and if you push rapidly, there is a risk of systemic embolization. These are the complications: fever, pain, ulcers caused by inflammatory response or a leakage of the agent. You can use a balloon compression, use mechanical compression to keep the agent localized and prevent it from spreading through the bloodstream. This is how you prevent the extraction. So comparing with the endoscopic varicose ligation with the sclerotherapy, you will have a lower rebleeding and complications and varicose eradication than sclerotherapy. Of course, sclerotherapy can be used in these settings, as I told, when the field is not clear, or in young patients, commonly people use sclerotherapy in EHPO bleed. So esophageal band ligation is the most effective primary treatment, outperforming both EST, and gastric banding is distinctly the most effective option. So management following the failure of endoscopic management, I will proceed with those patients who don't respond to your varicose ligation. So high failure rate, I already told, carries 5 to 20% of patients, depending upon the HVPG. The endoscopic retreatment, you can proceed the 2 to 3 endoscopic sessions can be carried out within 24 hours. The bridging therapy is, according to the Babino 7 consensus, they are recommended a self-expandable metallic stent as a safer and preferred option for traditional balloon tampering, which has been used in peripheral centers where endoscopy is not there. They can use preliminarily the Sengstaken tube to prevent the bleed. They can subsequently shift to a nearby center where the specialist and the endoscopic equipments and facilities are available. The ultimate rescue, as I already told my radiology colleagues helping us with the tips, is carried out in cases of refractory UGA bleed, which is a very good investigation modality to the arrest the bleed. And alternative interventions include the balloon retrograde transvenous obliteration, blocking the varices directly, and surgical rescue. So the salvage therapy, transitional hemostasis can use the interventions like SEMS and balloon tamponade, and pharmacological already described by my previous speaker. And the salvage procedure is TIPS and the surgical risk. Final option for end-stage cirrhosis who have MELD more than 30 or a TIPS contraindication, we have to proceed with the liver transplantation. So, yeah. Right. Coming to the self-expandable metallic stent, which is emerging bridging salvage therapy for uncontrolled bleed when the primary treatment fails. Strongly recommended by ESGE, several consensus have been arrived by Babino 7, ASLD as a superior alternative to balloon tamponade. Highly effective, stops acute bleeding in 90.6 to 96% of the cases. Major advantages is easy deployment, can be safely lifted for 7 days, but only the disadvantages are the cost. Patient, because banding will be finished within a cost of 10 to 15,000, whereas the SIMS alone cost around 40 to 45,000. And of course, we cannot answer the patient because of the risk of the migration of the stent. The stent migrates, then the patient is at risk of bleed. We cannot wait out the attenders because the rebleed is high, up to 35% due to migration of stent. This is the stent which is commonly deployed. Is the LR Danis stent. Is having a length of 135 mm. There's the end diameter of 30 mm and a mid diameter of 25 mm. And we can remove the stent with a wire. That is a loop given approximately. So coming to the balloon tamponade, of course, it's very used, and it's a question asked among postgraduates during the Viva session. So what are the types of balloon? There is a Sengstake Blake tube to physically squeeze bleeding viruses. Shunt in emergency. The 24-hour rule, it must be removed within 24 hours. Why? Because it carries risk of esophageal rupture and aspiration and pneumonia, a common complication to keep it for more than 24 hours. Once deflated, bleeding restarts in over 50% cases. That's why I already told it can initially obliterate the viruses, give a compression tamponade, and immediately shift up to a center where all facilities and specialists are available. Because of these risks, modern guidelines prefer SIMS placement for balloon tamponade. So these are the balloons available, which has been now rarely used, but you need to know that the Lincoln Nicholas tube, which is used gastrically, having a gastric balloon common for gastric viruses, and you have a Sengstake tube, like tube which has got two balloons. One is gastric balloon, another is a esophageal balloon. One to obliterate first we inflate the gastric balloon and pull it, and we obliterate the fundal varix, and subsequently we inflate the esophageal balloon and obliterate the esophageal varices. And there are two ports for aspiration to prevent the risk of aspiration pneumonia. And subsequently another tube is Minnesota tube, which has got 4 ports. So other interventions are hemostatic clips and hemostatic powders and APC. These cannot be recommended as the patients start to rebleed in case of whenever you apply a hemostatic powder. These can be adopted or practiced in cases of any small ulcer or bleed. We can spray the powder, hemostatic powder over there, but not in case of varices. And APC also not tried. It can be used in case of any non-varicose bleeds. Coming to tips, as my radiology colleagues will be far better, give more information about tips. It should be done within 72 hours of the initial hemorrhage. Can be used as in cases of refractory bleed, upper GI bleed, where you cannot control the bleed within 3 sessions, that are kept out within 24 hours. Best to refer to your friend who is an expert in intervention radiology, like Santosh Karthikeyan, who can do and very well help us. And the eligibility criteria is child book class less than 14 points, or a child book class B more than 7 points, and a HPPG more than 16 mm at the time of marriage. There's what are the rescue tips? This uncontrolled varicose bleed should be considered for rescue tips within 24 hours, preferably less than 8 hours, and failed first line therapy. Indicated when combined pharmacological and endoscopic therapy fails, and a recurrent bleeding indicated for patients who experienced recurrent esophageal varicose bleeding and did not previously receive a preemptive tips. This is a fully evaluation chart. I think I highlighted all the points. Initially, we have to resuscitate the patient. You have to start give the trial of pharmacological medications, vasoactive medications like optoid or terlipressin, and you have to give antibiotic prophylaxis when they are at risk of aspiration and they're bout, massive bout. We have encountered with massive bout while doing banding itself. Even it's almost more than 1 meter we have seen bleed. and temporarily withhold antiplatelets and anticoagulants. Of course, it is an emergency, so it is not mandatory. We have to go ahead in case of life saving. We have to proceed even then if we are on anticoagulants. And endotracheal intubation, I already told, to prevent the risk of aspiration. To perform an endoscopy ideally within 6 to 12 hours, and the EVH perform the risk stratification. If the PBL endoscopic banding, varicose ligation, EV, and control low risk of recurrent bleeding and high risk of recurrent bleeding, consider preemptive tips within 72 hours. If there is a persistent endoscopic varicose hemorrhage, consider tips or esophageal stenting. If not, finally refer the patient very good liver transplant. These are the reference from which I have my topic there. Thank you for giving me an opportunity.
It's a very good presentation, sir. As you said, SEMS is a very good bridging modality till we shift the patient for tips. Any other contraindications, or in terms of if the patient is having esophageal as well as fundal varices, can we deploy stents, SEMS?
So initially, whenever the patient is having gastric varices with RCS, for any bleed, if you suspect, first you have to do an endoscopy and you assess the bleed, because most patients, the esophageal varices may not have blood. You have to proceed with the ideally any endoscopy for people who are practicing surgeons or a surgical gastro or any of my colleagues. You have to do a fundus examination. You have to see whether the bleed is from the gastric varices or esophageal varices. If the bleed or any ulcerations or any RCS in the gastric varices, you have to first proceed with the glue injection, depending upon, since the patient is having blood from the gastric varices. And you have to first address the gastric varices simultaneously. If the varices are large, esophageal varices are large with RCS, we can do with the endoscopic varicose band ligation also. But before proceeding with any glue therapy, we make it a protocol to do any CT angio to see any feeders or collateral, because many cases what the varix we see in the lumen is not the thing. There is a large amount of feeders which we not able to control even after a glue injection. So better now we made a protocol in our department to do a CT angio to rule out any feeders. How much is this? If there is a large varix having multiple feeders, better to refer to our colleagues to do with a coil simultaneously with a glue injection. So that would be the protocol, I think.
How to manage patient with a massive post-EVL ulcer bleeds?
Post-EVL ulcer, I have already told, it's very tough to treat, but you can initially plan hemoclips and won't do good. So ideally, you have to do a polydocanol injection into the varices. Most often, the post-EVL ulcers are spontaneously. We need not intervene. Suppose the patient is bleeding spontaneously, we have to inject polydocanol. A glue can be injected, and it has been tried. I think there is no role of hemoclips. But in case of any post-EVL ulcers, we have seen ulcers in the case of GOV also sometimes we have seen, and you can very well ban there. Even a GOV also we have done. So I think you can, most post-EVL ulcers will do arrest spontaneously. If at all not doing, you can proceed with the polydocanol or glue injection.
Okay. When to give blood transfusion, sir? What's the cutoff of blood transfusion?
Cutoff, as I already told, we have to first assess how much is the hemoglobin level initially, and you have to assess whether the scores. There are the bleeding scores. We have Black score and Lockhart score. We have to assess the patient. We have to see whether the patient is hemodynamically stable or not, depending upon his BP, heart rate, and output, oliguria, everything. We have to study the patient, and if his hemoglobin is more than 8, we may not wait. We can reserve a blood and we can proceed with our interventions. My opinion, usually I practice, and they are less than 8 grams, I give a PRBC and we proceed with the transfusion. Otherwise, we keep a blood in reserve and we proceed with their interventions. The most patients don't bleed.
Any question from the floor? If there's no further question, we close the session. Thank you, sir.
Thank you, sir. May I now request Dr. Periyakarpan, President, to hand over the mementos to the moderators and the honorable speaker. Dr. Subramaniam, can you come over to the stage, sir? We thank both the speakers and all the moderators for sparing their time on a Sunday. Thank you so much, sir. Dr. Karthikeyan, you can hand over the momentous to the moderators. Thank you, sir. Our heartfelt thanks to all four of you. Our next session will have 3 talks within a package. Thank you, everyone. The moderators for the next set of sessions will be Dr. Sivasubramaniam. Sir, can you please come over to the stage? Professor, Medical Gastroenterology, GMKMC. Dr. Avi Kumar, Consultant Surgical Gastro. He is on the way. Dr. Ilango, Consultant Interventional Radiologist, PSD Hospital, Coimbatore. And Dr. Rangarajan Rajagopal, Assistant Professor, IR, AIMS, Madurai. Dr. Avi Kumar will join us shortly, while I request the other 3 moderators to come over to the stage. Our first talk in this session will be by Dr. Rajesh, Senior Consultant, Interventional Radiology, Rajagiri Hospital, Cochin, on tips in cirrhosis liver and beyond.
Good morning. Am I audible?
Very much, sir.
Good morning. At the outset, I would like to thank the Tamil Nadu Pondicherry ISVR chapter and especially Dr. Karthik for the invitation. I bring greetings from the God's own country, and this is my first time in Salem. It's for a talk which is very close to my heart. I hope I can do justice to it. We've already seen the management of portal hypertension, the medical and the endoscopic management. What can be done when the endoscopic management fails? That is what my talk would be. Basically, role of tips in cirrhotic portal hypertension and non-cirrhotic portal hypertension. I will not only be talking about bleeds, I will also be talking about the other manifestations of portal hypertension like ascites and hypothorax. Now, what is TIPS? It's basically an acronym for transjugular intrahepatic portosystemic shunt. If you break it down, transjugular basically means that TIPS is a minimally invasive procedure. It's audible. Oh, so it's a Okay, so should I use this? So TIPS is basically a minimally invasive procedure which is usually done from the right internal jugular vein. You make a small pinhole in the jugular vein, go into the heart. That's why it's called intrahepatic. And then portosystemic shunt. So basically you're creating a communication between the portal circulation and the systemic circulation. So you're putting a stent between the portal vein and the hepatic vein. Why is it done? It's basically done for portal hypertension, be it cirrhotic or non-cirrhotic. That stent which you have put between the portal vein and hepatic vein, it's going to bypass the liver parenchyma and the sinusoids, and it's going to decrease the portal pressure. So it's done mainly to alleviate symptoms of portal hypertension, could be variceal bleed, could be ascites or hydrothorax. But it does come at a cost. Since you are creating a bypass between the portal and systemic circulation, the gut-derived neurotoxins will directly now go into the systemic circulation, and the incidence of hepatic encephalopathy will rise to the tune of almost 30 to 50% after TIPS. And since all that blood from the gut is now going directly into the right heart chamber, TIPS is going to increase the preload and precipitate cardiac failure in a significant proportion of patients. So this is in a nutshell what TIPS is and what are the complications. Now in the next 25 to 30 minutes, we'll see the overall picture, how TIPS was devised and how the indications of TIPS are now changing from the last resort to a more early evidence-based intervention. We'll see the role of tips in varicose bleed, in ascites and hydrothorax. And then something very important, how do you select patients for tips? Once you have a patient who has an indication for tips, how do you decide that the benefit will be more than risk in this patient? A little bit about the device, because something new has come up in the last 2 to 3 years. Post tips, how do you manage these patients? Very briefly. And then the role of tips in patients who have non-cirrhotic portal hypertension. And just a word about the future directions, where we are heading in terms of tips. So let's start with the context and the shift that is happening in the tips world. So in the late 1980s and early 90s is when tips was devised. It was mainly devised as the last resort for patients who had refractory varicose bleed. So a patient came to you with esophageal bleeding, you tried endoscopy, it did not work. What to do? That is when this tips was devised. It was usually used as a last resort. So you would understand that it was offered late to sicker patients. And we only had bare metal stents at that time, which had a very high dysfunction rate. So the reputation of tips in the late 1980s, early 90s was built on futility and encephalopathy. So everybody thought that this is the last resort. It does not work. Many of the patients are still dying due to other reasons. So maybe we should not go ahead with this procedure in most of the patients. Cut to now, in the last 10 to 15 years, we have now level 1A evidence that tells us that preemptive tips in varicose bleeding saves lives. It has already been partly discussed by my previous speaker. We should also discuss tips early in ascites, not wait for the ascites to become refractory. Do it early to have better results. Now we have covered dedicated tip stents, and we also have, not in India, but at least in the West, we have controlled expansion stents. So we'll briefly discuss that. And most importantly, a patient for tips is now decided by a multidisciplinary team rather than one number which is made. So let's start with where you can use tips. Varicose bleeding, we have already seen the medical and the endoscopic management. So you have a patient with index esophageal varicose bleeding. The initial assessment, resuscitation, and endoscopy has to be done. That is the first step. Now, after endoscopy, there are two scenarios which can arise. Either the patient will have a persistent bleed, which cannot be controlled on endoscopy. In such a scenario, you have to send the patient for a salvage or rescue tips. There is no confusion here. It's very well described in literature. It's done practically in all the centers, and it was also discussed previously by the speakers. Persistent bleed after endoscopy, you have to send the patient for a salvage or rescue tips. What about patients in whom the bleeding was controlled on endoscopy? Now, here is where the algorithm gets a little confusing. Most of the centers still continue conservative management. So the bleeding was controlled on endoscopy, patient is stable, you continue vasoactive drugs for 3 to 5 days. If the patient does not bleed again, which happens in 80% of cases, you can continue your secondary prophylaxis with beta blockers, send the patient home. If the patient has a repeat bleed on secondary prophylaxis, there is a role for tips. If, however, the patient has an early rebleed, which happens in around 20% of cases, and if that bleed is mild, you can do a repeat endoscopy. That bleed is controlled, you send the patient to the right side of the algorithm. If it's not controlled, you send the patient for a rescue tips. And if that early rebleed was severe, you can still send the patient for a rescue tips. So in this flow chart, there are two indications for tips in varicose bleed. One is a salvage or a rescue tips where endoscopy fails, and one is for recurrent bleeders where the secondary prophylaxis fails. So let us look at these two indications first, and then we'll talk about what is preemptive tips. First is salvage or rescue tips. Uncontrolled varicose bleeding despite drugs and endoscopic therapy. It's the most effective way to secure hemostasis in refractory variceal bleed. One thing to understand here is that in emergency scenarios, in patients who require a salvage or a rescue tips, it is very easy to select these patients because it's a life-saving measure. If the patient has hyperbilirubinemia, encephalopathy, coagulopathy, these are not contraindications to a salvage or a rescue tips. This is not me saying, it's there in Bavino 7. Having said that, there are some scenarios where you should not do even a salvage or a rescue tips. If the patient has an arterial lactate of more than 12, this is the most important indicator which has been shown in studies to tell you that even a salvage tips is going to be futile. MELD of more than 30, CTP more than 13, ACLF grade 3B, basically which means multi-organ failure, and uncorrectable hemorrhagic shock. So whenever patient comes to you for a salvage or rescue tips being referred by a hepatologist or gastroenterologist, what you should do is rule out the absolute contraindications first. Get an arterial lactate, see whether the patient is responding to fluids, calculate the MELD and CTP. If all these are within limits, you can go ahead with the tips. Even if the bilirubin is 7, even if the patient is in encephalopathy, even if the INR is 4. Again, this is not me saying, it's there in the Bavino 7. So these patients are easy to select. This is just an example of a salvage tips. You will see on your left, large coronary vein, which was giving rise to paraesophageal varices. Came with a bleed, endoscopy was tried, didn't work. So we went ahead with the rescue tips. And in rescue tips, something I want to highlight is that you always have to block the varices. It has to be done. It is all anecdotal, but we have seen that many of these patients, if you don't block the varices, even after tips, they will bleed. So we block the varices with glue and put a tips, and now you will see that the entire mesenteric blood is now bypassing the varices and the liver and going into the heart. So this is how beautifully tips can work if done at the correct time. What about secondary prophylaxis? Patients who were on non-selective beta blockers plus EVL, that still remains the first line. But if they bleed on that secondary prophylaxis, that is when you can do tips. You can consider tips earlier if the patient has any other complications of portal hypertension like ascites or PVT. And it also helps in refractory portal hypertensive gastropathy. Gastric varices will be discussed by my colleague later, but just briefly, in some patients with gastric and ectopic varices, you might, obviously you will try to do PART-1, but if it doesn't work or if the patient already has esophageal varices also, then tips can be done even for the first bleed. So just an example, this patient had both gastric and esophageal varices. You will see that I have put a plug in the shunt. I put sclerosant antigrade into the shunt, and then I'll put a tip stent. So that will take care of both the gastric and the esophageal varices. Ectopic varices, this was an interesting case, came to us with hematuria, not a known CLD, came to the urologist with hematuria. They did the cystoscopy, found some bulge of veins, and they got a CT done. And there was a large inferior mesenteric vein which was supplying the bladder varices. The technique again remains very simple. You go through the tips route, put glue into the IMV and the varices and put a tip stent. So in gastric and ectopic varices also tips works. Now we'll come back to this algorithm and you'll see the red box, the early rebleeding box. So this was highlighted by my previous speaker that 20% of patients who come to you with esophageal bleed are going to have a rebleed. Unfortunately, 50% of these patients are going to die. So just imagine you have a patient coming to you. You stopped the bleed on endoscopy. Patient was absolutely stable and still 10% of those patients are dying. So what can be done for this? This is where the role of preemptive tips comes in. So this slide was already shown previously. The idea here is that even if the endoscopy was able to control the bleed, there is a group of patients who are likely to rebleed. What are those? First is poor liver functions. Child PU C less than 14, child PU B with active bleed on endoscopy, or if you can do an HVPG at that time, it's more than 20, then there is a role for preemptive tips. Level 1A evidence, there is a statement in Bavino 7, which is written in the red, that preemptive tips has to be done within 24 hours, preferably within 24 hours, but at least within 72 hours. So we are talking about a group of patients who were stable after endoscopy, and still we are going ahead with early tips, because this brings down that 10% mortality to less than 2%. So just to revise, we have salvage and rescue tips for varicose bleed. We have now preemptive or early tips, and of course we have tips for secondary prophylaxis. So let us revisit this algorithm, and this is how it should be now. Patient with bleed, initial assessment and endoscopy, 2 arms, persistent and bleeding controlled. Persistent bleed, you have to send for salvage tips. Bleeding controlled, you have to stratify them into 2 groups, the high risk group and the low risk group. High risk group I've already shown, poor liver functions or HVPG more than 20. The high risk group has to go for early tips within 24 hours or at least within 72 hours. Low risk group, you can continue your conservative management and the rest of the algorithm remains the same. And now, in fact, studies are coming in which are showing that even in the low risk group, there is a small subset which might bleed again. So that is where the early preemptive tips is going. So 3 indications: salvage, preemptive, and tips for recurrent bleeders. Now, coming to another common indication, and this has not been discussed previously, is ascites and hydrothorax. And just like in variceal bleed, this is one indication where early or preemptive tips is coming up. In fact, we have enough evidence now. So whenever a patient with cirrhosis comes to you or us with ascites, we don't straight away send for tips. We do something called as a stepwise approach. We start with salt restriction, add diuretics, and if the diuretics are not working, which happens in most of the cases, the patient will be sent for a large volume paracentesis or tapping. And once this tapping becomes frequent, the patient has to go for a transplant. There is no doubt there. Transplant is the best option in this patient. Unfortunately, in our setup, many of the patients will not be affording for transplant. They will not have a donor. In those patients, TIPS is indicated. Now, the problem is that by the time this patient reaches to an IR for TIPS, it's already too late. They would be having tapping every week, or maybe every alternate day. They would have exhausted their liver reserves. The sarcopenia would have set in. They would have had multiple episodes of sepsis, electrolyte imbalances. And when you do TIPS in this scenario, mind you, this is very late for TIPS. But even in this scenario, TIPS offers a survival benefit. Again, level 1A evidence, 61% versus 40% 2-year survival. Now just imagine if you were to do TIPS early rather than waiting for it to become refractory, what the results would be. And there are 2 RCTs now, 2017 and 20, one published in gastroenterology and one in J hepatology. Both of them have shown that if you do TIPS when the paracentesis frequency is less, the results would be much, much better. So if you see the last line, the Bavino trigger, this is the Bavino 21 guideline, you will see that even the guidelines are now mentioning that the trigger should be more than 3 large volume paracentesis within 12 months. But very practically, if I were to tell you, what we do at our center is, the moment a patient comes for the first LVP, the patient who is on diuretics optimized, medical management optimized, salt restriction optimized, and still he comes for an LVP the first time, that is when our hepatologist and us will prime the patient that you need a transplant. If you can't do a transplant, then TIPS is an option. Only then you will get patients at the right time. So I think this is the message. In ascites, you should do TIPS early. So more than, in our experience, more than 90% of patients with ascites who undergo TIPS will have complete response. So this is 3 months apart, pre and post. Post TIPS, you'll see that ascites is almost completely gone. And the rest of the 10% who respond partially or do not respond will have other comorbidities. They will have coexisting renal dysfunction and other things, poor liver functions, who are coming late to us. So TIPS works wonders in ascites, more than 90% complete response. However, hepatic hydrothorax is a little more difficult because even in our experience, in hydrothorax, when you do TIPS, only around 60% patients will have a reasonable response. Rest of the 30-40% are not. So in hydrothorax, you have to push more for transplant, not like ascites, because TIPS still remains the most durable option in non-transplant patients, but it does not work as well as in ascites. Then, although there is no randomized evidence, but prospective studies have shown that TIPS works well for HRS, NAKI, not for AKI. In AKI, you have to find out the cause for AKI, treat it, and then send for TIPS. So these two were the most common indications for TIPS in a cirrhotic patient, variceal bleed and ascites and hydrothorax. But I think this is the most important section of the presentation because multiple studies have shown that the way you select your patients is going to decide whether your patient survives or not. It does not matter what your technique is, even if it's flawless. If you don't select your patients right, they are going to have a poor response. So how do you select patients for an elective TIPS? Emergency, I've already told, it's easier to select because there are very few contraindications. But in elective TIPS, most of these patients have already gone late. They have exhausted their reserves. That is why it's important to select them properly. Now, one thing to understand is that TIPS is going to affect multiple organ systems. So selection is a team sport. The nephrologist has to be involved, the hepatologist, the cardiologist, the anesthesiologist, the IR has to be involved. TIPS will decrease the hepatic perfusion because now the blood is going to bypass the liver and go into the heart. So it can precipitate acute liver failure in patients who are at risk. It will obviously increase the risk of encephalopathy. It will, and this is something which is underestimated, it can precipitate cardiac failure in up to 20% of patients at 1 year. Because now the preload, cardiac preload is increasing. And then it affects the kidneys, usually in a positive way. But since we're using contrast, it might precipitate AKI. So how do you evaluate these patients? First, you have to have a global picture, which is where MELD comes in. So MELD remains, I'm not talking about MELD sodium, I'm not talking about MELD 3.0, I'm talking about the plain old MELD. It remains the most accurate predictor of post-TIPS survival. Having said that, you should not refuse TIPS to a patient just because MELD is high. So a patient with MELD of 19 should not be an automatic refusal for TIPS. You have to tell them that the risk of TIPS would be more, but if it can be modified, so suppose a patient has a high creat due to HRS, you can modify that, bring the MELD down. And even if that is not the case, it should not be an automatic refusal. It has to be a multidisciplinary team approach. So EASL, again, this was the TIPS guideline which came in last year. It advises a MDT rather than an absolute MELD cutoff. There is no absolute MELD cutoff. You should not refuse TIPS to a patient who has a MELD of more than 18. Secondly, the most common complication of TIPS is encephalopathy. Now, how do you identify patients who are going to be at increased risk of encephalopathy? There is a very simple logic to this. Liver obviously metabolizes the gut-derived neurotoxins, but apart from that, kidney and muscle have a role in ammonia metabolism. So if you can remember this, liver, kidney, and muscle, anything that affects these three, the patient is going to be at increased risk of encephalopathy. The most important factor is any patient who has had a prior episode of encephalopathy which was unprovoked. No sepsis, no constipation, no electrolyte imbalances, still the patient had encephalopathy. This patient is likely to have a post-TIPS encephalopathy. Then sarcopenia, because the muscle mass has gone down. Then the liver related things, low albumin, advanced stage, poor liver reserves, poor liver synthetic function, Again, these patients will be at increased risk of encephalopathy. And then the kidney related stuff, low sodium and renal dysfunction. So this is in a nutshell the patient population who are going to be at increased risk of encephalopathy. But again, none of this, except that prior overt HE, except that none of this is an absolute contraindication. You can still go ahead, but you have to tell them the risk. Then the heart and the kidney. Heart, like I said previously, is always underestimated. You have to get a comprehensive echo. Look at the systolic and diastolic functions, the valvular functions, and any of this is severely deranged, that is an absolute contraindication to TIPS. Kidney, just like MELD, there is no cutoff. Like if creatinine is more than this, I will not do TIPS. Nothing like that. It has to be again an MDT. Even CKD patients can undergo TIPS. There are studies, including ours. CKD patients can undergo TIPS, but if you read the first line, renal dysfunction predicts encephalopathy, sepsis, and pulmonary edema. This has to be part of your counseling session. Now, once you have evaluated everything, the encephalopathy, MELD, kidney, and heart, then you rule out the absolute contraindications. Just like in emergency TIPS, in elective TIPS also, if the patient has severe cardiac dysfunction, severe pulmonary hypertension, valvular disease, or uncontrolled sepsis, severe HE, and unrelieved biliary obstruction. These are the absolute contraindications to an elective TIPS. Once you have ruled these out and the patient is fit, then you put your patient into one of these three boxes. This I've taken directly from the EASL guidelines. The green box is where you would be okay with going ahead for a TIPS because the benefit is more than the risk. In orange, you would be a little wary, and in red, you would rather not go ahead because the risk is more than benefit. So this is how we do it. We evaluate everything, rule out the absolute contraindications, and then stratify our patients into these three boxes and then tell them the risk. There is no black and white, it's all gray. You have to tell them the benefit and the risk and let them decide. So this is just a protocol that we follow. Patient comes for TIPS, you look at the indication, whether it's varicose bleed or difficult to treat ascites. If it's varicose bleed and it's an emergency TIPS, you rule out the absolute contraindications first. Lactate more than 12, MELD, CTP, uncorrectable hemorrhagic shock. If these are there, then you don't go ahead. If these are not there, you can go ahead with your salvage or rescue TIPS. Again, emphasizing that hyperbilirubinemia, HE, and coagulopathy are not contraindications to an emergency TIPS. If it's an elective setting, again, you get all your workup done, rule out the absolute contraindications, and then you stratify your patient into those three boxes and then counsel the patient accordingly. Then let them decide. So this is how we select our patients for TIPS. Now, just a word about the device because it's important. We have already talked about encephalopathy being the most common complication of TIPS. If you use a smaller stent, an 8 mm stent, the risk of encephalopathy is going to be half. But the problem in our scenario is that you put an 8 mm stent and the patient does not respond to ascites or hydrothorax. Now you are screwed because you cannot dilate an 8 mm stent to 10. So this is where the controlled expansion stents have come in. It's still not available in India, but in the Western countries, they've started using it. The advantage here is that you put your stent, you dilate it to 6 mm if you want, and then wait for the response. If the patient responds, well and good. If the patient does not respond, you can dilate this stent to 7, 8, 9, 10, whichever you want. So this is the advantage of a controlled expansion stent. This is something which is very, very recent. So I thought I'll just mention it. Now, once you have selected your patients nicely, looked at the indications, done a beautiful TIPS, after that, how do you manage these patients? So this is another important area where we have to work together with the gastroenterologist and hepatologist to get the optimal outcome for the patient. Post-TIPS prescription, first is beta blockers. So after TIPS, if the pressure has come down to below 12, there is no need to continue beta blockers. I'm talking about varicose bleeders. ascites, most of the patients will not be on blockers. Diuretics, you should continue for some time, and depending on the response, you can taper it. This is for ascites, not for bleeds. Something to emphasize, no routine anticoagulation or antiplatelet. There is no evidence for this. It's there in the guidelines. There is no need for anticoagulation after TIPS unless it's a Budd-Chiari or a PVR TIPS. And rest of the surveillance of cirrhosis continues as such. After TIPS, still the patient has to come every 6 months, get a scan done, get the blood test done, have a consultation with the gastroenterologist, because that surveillance has to continue. This is our follow-up protocol. Before discharge, we get a scan done to assess the stent patency. After discharge, at 1 month, we'll call again to assess the stent patency and look at the liver functions or any other complications. Then every 3 monthly for the first year, and then every 6 monthly. So this is more important for bleeders, because the ascites or hydrothorax patient will come to you. You don't have to call him. If the ascites recurs, that means stent is blocked. So they will come to you. For bleeders, this follow-up protocol is very, very important. It has to be strictly followed. Now, again, encephalopathy. Now there is evidence that for an elective TIPS, if you can start rifaximin 2 weeks prior to your planned procedure, then it decreases the incidence of encephalopathy after TIPS. Level 1B evidence. Once the patient has undergone TIPS, you obviously have to start the lactulose and rifaximin. And if the HE persists, there are 3 or more severe episodes of HE post-TIPS within 6 months, then you have to start thinking about reduction or occlusion of stent. This is how the encephalopathy is managed. Then stent dysfunction, like I told you, the portal hypertensive symptom will recur in patients with ascites, and it will recur within a week. The moment stent gets blocked, within a week, the patient will start developing ascites. So those patients will come to you. But in bleeders, you have to be very careful. You have to do a very dedicated follow-up. And once you're suspecting a stent dysfunction, you have to do a ultrasound, obviously. But if the ultrasound is normal in a patient who has had recurrence of portal hypertensive symptom, you should still go ahead with a venogram, a tipsogram, and pressure measurement. Because many a times there will be small pseudointimal hyperplasia, the pressure would be high, and these patients do very well with relining of the stent. Now, this was about TIPS in cirrhosis. And now we'll just talk about what is the role of TIPS in patients with non-cirrhotic portal hypertension. The first scenario is portal vein thrombosis. Portal vein thrombosis was long considered a contraindication for TIPS. But in the last 5 to 10 years, multiple studies have come in which have shown that you can do TIPS in PVT, and in fact, it has become an indication for TIPS. Now, portal vein thrombosis can be present in both cirrhotics and non-cirrhotics. In cirrhotics, why is it important? If you assess the patients who are going for a transplant, 25% of these patients will have some sort of a PVT. It is important for the surgeon because when you do a transplant for a PVT, it is an independent predictor of morbidity and mortality at 1 year, because many a times the surgeon is not able to do a portoportal anastomosis. So that is why patients who are likely to go for a transplant and who have PVT, which has not responded to anticoagulation, there is a role for PVR TIPS, portal vein recanalization TIPS. So what we usually do is we'll re-establish the patent portal axis, put a stent, wait for 4 to 6 weeks for the thrombus to completely dissolve, and then send the patient for a transplant. So this is called as pre-transplant PVR TIPS. This is where there is emerging role for TIPS. This is an example of pre-transplant PVR TIPS. You will see the first image, completely occluded portal vein. We did a TIPS, and you'll see that even after TIPS, there was some residual thrombus, but we left it as such. And this thrombus usually resolves by 1 month. After that, the patient can go for a transplant. And then a more difficult scenario is non-cirrhotic PVT or EHPVO. In these cases, the portal vein is completely obliterated. So you are usual transjugular approach might not work. You might have to go transplenic, put a balloon or a snare, then access that balloon or snare from the transjugular approach and put a stent. Second scenario, and this will be discussed by Shamkumar sir in one of the later lectures, Budd-Chiari syndrome. This is something where TIPS has fantastic results. I mean, in cirrhosis, the patient, we know that say patient is not going to survive long, even after a TIPS without a transplant. But in Budd-Chiari, the results are so dramatic and the patient survives for, I mean, they might have a normal lifespan. So this is something where TIPS is very, very useful. Usually we go by a stepwise approach. We start with anticoagulation. If it doesn't work, you go for angioplasty or stenting. If that doesn't work, then you can go for a TIPS or a DIPS. Patients who do not have any hepatic vein, completely obliterated hepatic veins, in those patients, you can directly go for a TIPS. And then if that doesn't work, you have to go for a transplant. Now, one thing I want to highlight here is that Budd-Chiari syndrome, the treatment is one part, but diagnosis itself is difficult. So this patient, she came to us from Mumbai. From 2014 to 2022, for 8 years, she was undergoing LVP every week. 8 years. She was diagnosed as cirrhosis. They were doing LVP. She was malnourished, sarcopenic, multiple complications had happened in between. And we got a CT done. It was classic Budd-Chiari. And her portal vein was also thrombosed. So we went in from the IVC into the thrombosed portal vein, and we could re-establish the patency. And this is at last year, 3-year follow-up. You'll see a patent stent, right? I mean, it's not visible here, but the stent from the SMB to the IVC was patent. So we are all diagnostic radiologists first, I believe. So whenever we are seeing a patient with deranged liver functions or ascites, especially a young female, you have to look at the hepatic vein. Don't assume they are normal. And many a times that happens. So you'll be amazed at the number of Budd-Chiaris you pick up, and we get a lot of these patients who are misdiagnosed. So if you can diagnose it, only then you can treat it. So that is something about Budd-Chiari which is worth thinking about. Then the group of patients with portosinusoidal vascular disease or PSVD, now it's called as NCPF also. The same rules that apply for cirrhosis apply here. You can do it for, usually for varicose bleed. These patients will not present with ascites most of the times. They will have varicose bleed recurrent. So the same rules apply. The advantage, again, just like in Budd-Chiari, is that the long-term prognosis of these patients is much better compared to cirrhotics. So when you're doing it for recurrent varicose bleed, they will do well for a long period of time. Then something called as neoadjuvant TIPS or pre-surgical TIPS. This is in patients who are going to undergo extrahepatic abdominal surgery. And there are some studies, including from the Barcelona group, which have shown that if the HVPG is more than 16 in these patients, then you should do a TIPS before surgery. Wait for 4 to 6 weeks and then send the patient for surgery. But it is all retrospective data. There is, I mean, none of the guidelines endorse it yet. It tells you that after TIPS, the risk of decompensation and bleeding is less, but not proven. We have done in some cases, the results have been okay. And this is the last indication, TIPS in patients with HCC. So depending on the extent of HCC, if you have a small solitary lesion, which is not in the expected path of the TIPS stent, then you can easily go ahead with TIPS. There is no contraindication. And after TIPS, you can take care of the HCC. But even in patients with advanced HCC, with portal vein tumor thrombus, now there are studies which have shown that you can do TIPS as a palliative procedure. Patients who have refractory ascites, recurrent or refractory bleed with PVTT, tumor thrombus, you can still do TIPS. It does not disseminate the tumor. It's been proven now. But obviously, it's a palliative procedure. Something to remember is once you have done tips for HCC. After that, when you're trying to treat the HCC, especially when you're trying to do a TACE, you have to be very, very careful, because tips is going to decrease the portal perfusion in that part of the liver. Then if you go and embolize the artery also, the liver might go into ischemia. So that is why for smaller lesions, post tips, you should prefer either ablation, or if a transarterial therapy is required, TARE is preferred over TACE. The last scenario is post-transplant tips. So the indications are the same. It's usually done for persistent ascites after transplant. But unfortunately, when you do tips after transplant for ascites, the patients for some reason do not do as well. Again, the response rate is around 50 to 60%. We don't know the reason, but it can be technically done, and around half the patients would respond. So this is just an example of tips which was done in a patient with HCC. This was in 2022. Small lesion, gross ascites, preserved liver functions, preserved kidney functions. We did the tips. We waited for 3 months for the ascites to resolve. Luckily, the lesion did not progress. And after that, the initial plan was to do an ablation. But you will see that the stent is very close to the lesion. So we did not do ablation. We sent the patient for SBRT. And post SBRT, this is 6 months post SBRT, you will see that the lesion is completely gone. And this patient still comes to us. It's been 4 years, no recurrence of HCC, no recurrence of ascites. His liver functions are still preserved. Kidney functions are okay. Performance status is good. So small HCCs should not be considered a contraindication to tips as long as it does not come in the way of your stent. Like I said previously, even in advanced HCC, you can do tips as a palliative procedure. Just a slide on future directions. Now, in the last 3 to 5 years, some studies have come up which have shown that tips not only decreases the portal pressure, it also does something else. What does it do? Because of the decrease in portal pressure, the enteropathy, the bowel edema decreases. That will decrease the gut permeability and bacterial translocation, and ultimately decrease the systemic inflammation in patients who have cirrhosis. So this is, again, obviously it's all speculative, but post tips, it has been shown that after the first month there will be a hike in inflammation, but after the first month, many of the patients have a decrease in systemic inflammation. And it has been studied by measuring the levels of IL-6 and other inflammatory markers. And that is why Bovino 7 has introduced, I mean, it's not a mandatory thing, but they have mentioned that tips can be used as a measure for recompensation. So you have a patient with ascites who was an alcoholic. He stopped taking alcohol, so you've taken care of the etiology. Then you do tips, take care of the ascites. These patients are likely to go into recompensation. So they will be free of their symptoms for a significant period of time, even without medications. So this is something exciting that's coming up. Tips as a measure for recompensation, something that decreases systemic inflammation, and as a disease modifying agent. So hopefully Bovino 8, which is going to come next month, will have something on this. Take home points. Tips is not the last resort. It is now a strategic tool. It should be done early in patients with bleed and ascites. Preemptive tips in varicose bleeders saves lives. Even in ascites, you should discuss tips early. For us IRs, we should use the smallest effective shunt. We have now switched over completely to 8 mm stents. Till 6 months back, we were using 10 mm stents in all patients. But now, last 6 months, we have switched completely in all patients to 8 mm stents. And it works even in patients who do not have cirrhosis. Thank you.
Thank you, sir. That was very lucid. So, are there any questions from the floor?
The floor is open for discussion.
Yeah.
how will you choose the patient for TIPS versus BRTO in gastric varices?
Okay. So if the patient has only gastric varices, he does not have any other portal hypertensive symptom like ascites, like HRS, like HPS, or esophageal varices, then this patient should go for a BRTO. There is no need for additional tips. But if the patient has gastric varices with esophageal varices, or with refractory ascites, or with hepatorenal syndrome, any other complication of portal hypertension, which ultimately requires a TIPS, then you would rather counsel them for TIPS plus the shunt has to be blocked. PART-2 has to be done or BRTO has to be done. But TIPS might be added to that, depending on obviously the contraindications, the liver functions and everything. If he is a candidate for TIPS and there are, along with gastric varices, other portal hypertensive complications, then TIPS should be added to BRT or PART-2.
Yes.
Excellent presentation, sir. I have a doubt regarding the size of the stent. For what is the size of the stent you suggest for DIPS?
DIPS. So see, DIPS is in patients without cirrhosis, right? So in those, they are not, I mean, very unlikely to develop hepatic encephalopathy after TIPS. So we still use 10 mm stents only in DIPS and in non-cirrhotic patients.
Okay. Thank you.
I just have a thought. So you were telling 20% of patients develop cardiac complications
in the long term.
Is
1
this
to 2
in,
years
is this over and above the natural history of cirrhosis, or?
So most of the cirrhosis patients, it's been seen, have some sort of a cirrhotic cardiomyopathy. It will be clinically insignificant, but once you do TIPS, many of it will get unmasked. So long-term studies have shown that 1 year and 2 year follow-ups, if you see, at 1 year, almost around 10% of patients will have some sort of a cardiac issue. Now, whether it was already there or something that developed after TIPS is obviously difficult to say, but multiple studies have shown that the risk of cardiac complications is quite high.
And it's related to the TIPS and not
Has
to the
to be, because at the time of TIPS, we did an echo and it was normal. So if they're developing after TIPS with a normal echo, then we have to assume that it is due to TIPS.
TIPS in renal failure. For example, creatinine cutoff. No.
So if it's an acute kidney injury, then TIPS is not indicated. You have to find out the cause for the acute renal injury, correct it, and then still there is an indication for TIPS, you can go ahead. In CKD, TIPS can be done. Regardless of the level of creatinine, there is no cutoff. But with the caveat that these patients are going to have a significantly increased risk of hepatic encephalopathy, immediate post-procedure pulmonary edema, sepsis, and worsening of renal dysfunction. So it has, so unless the patient and bystanders are really motivated, you should not go ahead, to be very, but it's not an absolute contraindication.
Thank you, sir. Anyone on the floor?
Good morning. First of all, I compliment you, Dr. Rajesh. It's such a wonderful presentation.
Thank you, sir.
You have covered every part of TIPS. I just would like to highlight that over a period of time, whatever we are considering as a contraindication for TIPS, today all of them one by one are getting converted into an indication.
Very correct, sir. Very
so that most patients are getting benefited. It's only that certain careful steps we have to take. Example, concerns about hepatic encephalopathy. So when we have hepatic encephalopathy concerns, we plasty for 8 mm and deliver a 10 mm stent. And over a period of time, either it will gradually expand, or if needed under local anesthesia, we can expand it on a future date. Thank you.
Thank you, sir.
Thank you, sir. May I now request Dr. Preetham to hand over the memento to Dr. Rajesh. Thank you so much, sir, for coming all the way from Cochin. I request the moderators to stay back because you have another 2 sessions left. Thank you, Dr. Rajesh. Our next session will be surgical shunt in the era of TIPS by Dr. Sivashankar, Professor HOD, Surgical Gastroenterology, GMKMC, Salem. Over to you, sir.
all, respected chairpersons, senior faculties, and dear friends. So this is going to be interesting topic, but after the advent of tips, what is the role of surgical shunts? So we have some of the important strengths one has to know before considering tips in some situations, particularly some of the shunts like Rex shunts and PSRS shunts, particularly in non-cirrhotic patients, one has to consider. So the burden of portal hypertension, almost 50% of cirrhotic patients harbor varices at diagnosis. They have 10 to 15% annual bleeding risk in medium and large varices, and 15 to 20% 6-week mortality after a first variceal bleed, and 60 to 70% risk of rebleed without secondary prophylaxis. So variceal hemorrhage remains a leading cause of death in decompensated cirrhosis. So the first line of management, as you know, that it is endoscopic and pharmacological management, but subset of patients still require shunt, particularly refractory and recurrent bleeders. So by means of tips or surgical shunts. So 3 physiological families. So the portoportal restoration can be achieved by mesorex bypass. That is SMV, mesenteric venous inflow, is routed to the left portal vein at the rex recess, the umbilical fissure of liver. So the other one is portosystemic decompression. That is mainly we consider PSRS, that is proximal splenorenal shunt, that is diverting portal pressure to the systemic veins. The other one we will all know that radiological tips shunt. So the type of shunt surgeries, nature of underlying disease, degree of hepatic compensation, indication, urgency, and venous anatomy, and experience of surgeon all depends. We have to consider. The use has decreased because of advent of tips and liver transplant. So there are some role of shunts when no access to tips. That is in situations like emergency control of variceal bleed, reduce portal hypertension in patient awaiting transplant, or relieve intractable ascites, and really reduce bleeding from ectopic varices. So there are some situations, sinistral portal hypertension, splenic vein thrombosis, sometimes splenectomy may be the solution for that. And bleeding from fundal varices, ectopic varices, failure of endotherapy, rebleed following defaulter of endotherapy, refractory ascites. So all, if tips is not possible, shunt is option. There is some indications, symptomatic hypersplenism and rare blood group. So what is the rationale? As you know that the elevated portal pressure drives varix formation and lead to rupture and bleed. Shunt will decompress the portal system by diverting flow to the systemic circulation. The effective decompression controls bleeding almost universally. So the 2 options, tips and surgical shunts. So the surgical shunts, we have to, there are many, but we have to consider few only, because the portocaval total and all has been outdated. So non-selective shunts like proximal splenorenal shunt, and selective shunts in some situations, DSRS. And portoportal is a very important one. Rex bypass is fundamentally different because it diverts blood to the liver. So what is the comparison between tips and surgical shunts? So the invasiveness, of course, very less with the tips. We need a laparotomy for surgical shunts. Sedation may be enough for tips, but general anesthesia required in shunts. Hemodynamics, total non-tunable diversion in tips. But in surgical shunts, it can be tunable, it can be selective, it can preserve hepatopetal flow. That is very important. And durability, again, depends on the covered stent or bare stent. The covered stent will have a markedly improved low re-intervention rates. And but in surgical, there is low re-intervention and excellent long-term results. And the effect on future transplant, minimal interference with the tips. And in selective shunts, we can largely preserve hilar anatomy. So best suited situations are acute, urgent, or situations. Tips may be very useful and excellent. And in surgical, when there is elective situations, non-cirrhotic patients, favorable anatomy, long-term horizon, in that situations, surgical shunts scores over. So the in patients with cirrhosis and acute high-risk variceal bleed, tips is better situations. And in pediatric extrahepatic portal venous occlusion and pattern recurrences, we can go for Rex shunt. In NCPF, that is a non-cirrhotic portal hypertension with the fundal varices and hypersplenism, we can go for proximal splenorenal shunt, which is having a durable decompression, and we can have a splenectomy benefit also. In Bachari, most of the patients landed with the transplant, but in some situations we can go for mesoarterial shunts. So this is the Rex shunt. So this is the where we are anastomosing. We are connecting Tnpy here. So we are connecting the superior mesenteric vein here to the left portal vein, left branch of portal vein at the umbilical fissure rectories. So by using conduit by means of internal jugular vein like that. So it preserves the hepatopetal flow in non-cirrhotic liver, preferred a surgical concept in children with the extrahepatic portal venous occlusion when rhexeresis and SMB are pattern. In these situations, these rections will have the best solutions. So we have to identify the rhexeresis in the left portal vein and mesenteric flow using a superior mesenteric vein, and conduit by means of most often the internal jugular vein is used. So it is using the left portal vein. So we can have a conduit by means of internal jugular vein, otherwise we can go for coronary vein also, and we can have a end-to-side anastomosis of left portal vein, and thereby we can achieve hepatopetal flow. So some other situations we can have a splenic vein also. So what the literature says, there are many studies prove that there is in this pediatric patients with non-cirrhotic portal hypertension, Rex is giving excellent outcome. So the other one is proximal splenorenal shunt. It is a splenectomy with the proximal splenic vein anastomosed to the left renal vein. It is a strong option in NCPF with the preserved liver function and bleeding gastric fundal varices. So useful when splenomegaly or hypersplenism are clinically important. Avoid the prosthetic graft, creates a large caliber, durable, decompressive pathway. So this is where the the splenic vein is anastomosed to the left renal vein. So the operative steps are splenectomy, and we have to mobilize the splenic vein and expose the left renal vein. End-to-site anastomosis, we have to verify the flow by Doppler, and post-splenectomy care we have to give to the patient. So we have one prototype of patient with a PSRS we have done for a 22 years male having upper GI bleed, and the parameters are all normal, liver function is normal, endoscopy shows large fundal varices. The portal Doppler shows the liver appears normal and cavernomatous transformation of portal vein. Spleen is enlarged and the pancreas is normal. Main portal vein is 1 centimeter, splenic vein 9 millimeter, left renal vein 12 millimeter. So we have proceeded with the PSRS. So this is where we have to do laparotomy, and we have to do the splenectomy. We have to release the adhesions, perisplenic adhesions. We have to release carefully, and we have to, because there's so many extensive collaterals will be there, so we need to ligate it individually, and we need to use the vessel sealer, and after releasing the vascular adhesions, and the splenic vein is carefully mobilized, and this is how we are dividing the splenic vein, and after that we are mobilizing the splenic vein from the this is how the splenectomy has been done, and after that we are mobilizing the splenic vein from the pancreatic body and tail. We have to mobilize up to the level of confluence with the SMB. We need to mobilize thoroughly so that it can reach the left renal vein without tension, and this is how the left renal vein is isolated and mobilized. And you can see the gonadal vein is joining left renal vein. This is how we are applying the vascular clamps to the left renal vein, and we are creating we are dividing the left renal vein for anastomosis, and this is how the splenic vein distal end, and here we are making a opening in the left renal vein, and after that we are anastomosing the splenic vein to the left renal vein. This is how it is being achieved. We have to use the 5O proline sutures continuous, so it will be very straightforward. Actually, vascular anastomosis we can achieve, and we have to allow the growth factor to fill up. So while tightening the sutures, this is how the the proximal splenorenal stent has been achieved for this patient. And post-operatively, we are monitoring, and this is how the stent is working very well. So thereby the patient is almost symptom-free for quite a long period. We are following the patient for almost for 4 to 5 years. The patient is doing well. So there are very good studies from AIMS showing very good results with the PSRS. So the high volume surgical centers, and we have to select the patient carefully. So the patient should be having a non-cirrhotic portal hypertension, and sometimes patient may be having hypersplenism. In these situations, this PSRS is working very well. And other situations, we are going for Sugiura procedure also, that is devascularization. When you open, you can see large fundal varices. This is how it looks like, the fundal varices perioperatively. So very huge varices, sometimes bleeding very much, and this is the massive splenomegaly and extensive collaterals around the spleen. And here we are doing a splenectomy by ligating the splenic artery first, and we are dividing the vasculatures, that is varices, collaterals all around the lower half of esophagus, and almost upper 2/3 of greater curvature and upper half of lesser curvature. We need to devascularize them thoroughly so that we can achieve very good results outcome. So this is how we are not doing a transaction. Without transaction we can have very good results, but in some situations like emergency fundal varices bleed, this devascularization is very useful. So the mesoatrial shunt also very rare because of advent of TIPS and intervention radiology and also transplant. So the Buchiari syndrome mesoatrial shunt is one technique still one can venture on. So the pooled evidence shows that the bleeding control is highly effective with the surgery, and the reintervention is significantly low. And encephalopathy definitely is low than with other stents. So the long-term patency and rebleeding, it is the covered stent and surgical stents are doing very good results. The contemporary indications are for surgical stents, portal vein thrombosis and cavernoma where tips may not be feasible, and pediatric portal hypertension, small hepatic vein or portal vessels. We have to be very careful. Otherwise, it is a REX shunt is very useful. When technically tips is not feasible or previously failed or occluded, we can go for surgical shunts. And non-cirrhotic portal hypertension with the preserved liver function, we can go for shunts. So this is how the practical decision algorithm depends on the anatomy and patient situations. When patient is having patent portal vein, urgent setting, intervention radiology available, patient is awaiting transplant. In this situation, TIPS is favorable. When portal vein thrombosis, cavernoma, when TIPS is may not be possible, and pediatric non-cirrhotic good liver function, long life expectancy, in this situation, surgery may be favorable. So take-home messages are, TIPS is a modern default for many cirrhotic decompensation pathways. REX shunt is physiological gold standard when pediatric EHPVO anatomy is suitable. PSRS, that is proximal splenorenal shunt, remains powerful in non-cirrhotic portal hypertension with the fundal varices, large spleen and hypersplenism. Devascularization surgery useful in emergency fundal varices bleed where intervention radiology setting not feasible. So choose the stent which that best answers the patient's anatomy and physiology. Thank you one and all for the patient here.
Thank you, sir. The floor is open for discussions. Sir, Ravi, sir.
Sir, what's the role of devascularization at present scenario, present era, sir? Role of esophageal devascularization.
That's what I have mentioned. Almost we have been doing very regularly. Almost we have 2 to 3 devascularization procedures when we are doing post-graduation.
Yes, sir.
But in these situations has been most often the surgery has been outdated by use of PRPO and other intervention radiology procedures.
But still NCPF with hypersplenism, still surgery is the gold standard, sir.
Yeah. Some
yes,
situations sir. Like clinic vein thrombosis or EHPVO, patient is a pediatric age group. In that situations, devascularization still has a role, and we have been doing very rarely, particularly when the patient is having large fundal varices. When the technique was not useful, the devascularization is very excellent results.
Fantastic presentation from the surgical side. See, just for the sake of discussion, I feel especially for Budd-Chiari syndrome, all of us surgeons and intervention radiologists like us, we undervalue the importance of hematologists. So I recently did a tips for a patient who had a Budd-Chiari, young guy, 22-year-old, long IVC occlusion, like almost below the renal vein, entire thing was occluded. So our surgeons chose to do a mesoatrial shunt. And the shunt, everything went well. Patient had a very uneventful surgical course. Post-surgery day 10, patient came with an acute occlusion of the shunt to us. And they tried Fogarty. Again, there was some issue with the atrial insertion of the shunt. So it was re-occluding 2 days, 3 days, every doctor, every CT that we did showing occlusions. Then they asked us whether we can do something. We had some small opening, so we did a dips for that patient. But before that, I realized something is wrong. Why the patient is getting recurrence, because there is no one single anticoagulation that you give acetylcholine and that's it. What we do in our hospital is that we always involve a hematologist. And they go for a lot of tests, so they find out the exact cause. There are a lot of mutations that we are not aware. And they accordingly treat those patients. And I found that those results, sometimes just giving steroids helps. There are certain conditions where just simple maneuvers, this helps, and then reocclusion it can be avoided. So just want to bring to this.
Yes, sir. Because of a long PTFE graft, they are prone to get occluded, mesoatrial stent. That's why we are not doing very often. But probably the hematologist will help in this situation.
Thank you, sir.
Thank you, sir. May I now request surgical gastroenterologist, Senior Doctor Satish sir, to hand over the memento to Professor Sivashankar. Thank you, Dr. Sivashankar, sir. The moderators can continue to take the seat for the last session of.
I personally thank IVRS team of Salem and Dharan Hospital for welcoming, inviting me to talk on this topic. Thank you.
Thank you, sir. The most awaited session of this day is our keynote address, which is integrating interventional radiology into multidisciplinary care in modern healthcare. And who else, none other than Dr. Matthew Cherian, is the right person to talk on this. He needs no introduction. He is the HOD of Interventional Radiology, KMCH, probably the first person to start IR in this region. Over to you, sir.
Okay, good morning. And I don't know, I should say thank you, Karthi, or not, because honestly, I'm feeling exhausted. I was traveling so much and I just came back last night from Mumbai. But I could not say no to Karthi, because Karthi is one of the, we train fabulous people, and Karthi is among the best we have trained. He's brilliant. And we were rather disappointed he didn't want to join us. And yeah, so also I really, really want to thank Karthi, because Karthi proved something which I never thought was possible. And that was to transform a three-tier city and make it an apex center for intervention. So that sort of transformed the way we look at IR. We thought of IR. When I started IR in 1990, we were one of the 3 or 4 people in India doing IR. And then when I started, Professor V.R.K. Rao told me that how can you ever try Coimbatore? I mean, this is not the place IR will start. Why don't you try Chennai, And we saw that it was easy to develop a two-tier city because it is easy to educate people around. And Coimbatore is, and now I can say around Coimbatore is the only place where we have got the largest number of biplane labs per unit area of space. We have got 6 biplane labs. Every IR only works with biplane labs, they don't work with a single plane, right? That was fantastic. And every IR procedure is done only by interventional radiologists again. which we've been able to hold and keep. And so that was easier in a smaller city. So when Karthik came to Salem, we said, will you have the number of cases? And now we realize he's doing extremely well, extremely well. We don't compare Vellore. Vellore, though it's a 3-tier city or 4-tier, I don't know if you want to call. But the fact is, it's been there for 150, 130 years. So congratulations to Karthi. And of course, his friend Santosh. I mean, another thing they proved that if people work together, you can do better work. So he actually gave me this topic and he said, can you tell something to tell how important it is to work together inside a hospital environment and how you can totally transform the way a hospital works. So transforming modern hospital practice to interventional radiology, you can transform the way a hospital runs. You can make a hospital move up several steps higher if you have interventional radiology working in it. So interventional radiology is the definitive factor differentiating life and death in common clinical practice. Now you got to remember this word. Interventional radiology is a definitive factor. I'm not joking. KMCH was transformed in many ways because of interventional radiology. We could do things that nobody can do. And we put the tagline, making the impossible possible, purely because we said we do things that nobody else can do. And I'll show you that as we go across this. When I started in 1990, people used to tell I'm doing experimental work. It was very difficult. When my first patient died, there was a whole mortality meeting with surgeons ganging up to tell me I'm killing patients and doing experimental work. Today, that is history. It is no longer experimental. The biggest challenge we have is changing the mindset of surgeons to understand the areas in which we can completely revolutionize your work. For example, in trauma, in case of peripheral vascular malformations, in AVMs, in interventional oncology, in aortic aneurysms, in many of these areas, as a team, you can do phenomenal work. I'm not including conditions like peripheral vascular disease, where you may completely be the beginning and the end of the treatment. So let me talk about trauma. How can you change trauma care? If you call yourself a trauma center and you don't have an IR facility, you are lying. You cannot run a trauma center today efficiently. What is the biggest challenge in trauma? Active bleeding. Who can arrest a bleeding best? The interventional radiologist. Let me assure you that. The rest is history. But unfortunately, many surgeons live in history and not in the current future. And I'll talk about that very soon. Now, when you do an open surgical exploration, especially on a sick patient, what are you doing? It's a massive physiological toll on the patient. Now, for example, let's just look at this story. Here is the patient who's come to your hospital who's pumping blood from an injured carotid artery. Will you go and say, let him continue to bleed when he's bleeding? He's going to hypotension, and I go to the surgery theater and open up his neck. No, you put your finger and stop the bleeding. That is where the change starts taking place, because highly invasive laparotomies and thoracotomies performed on critically unstable patient is always death or a massive amount of money till they die. So till now, the historical focus was disruptive. Open the abdomen, do a splenectomy, take up a large part of the organ, go inside, not find a bleeder, and he dies on the table. We are talking about something. Stop the bleeding, preserve the reserves, defer the open anatomical repair, and you will have a patient that goes home alive. It is so important to do this because of these factors. The patient comes in hemodynamic shock. Patient is presented with a severe trauma, fracture to the pelvis, injury to the great vessels, or an aortic damage. He is in shock. Intervention percutaneously locates and plugs the bleeding source immediately. It is gentle. It doesn't destabilize the patient in any way. Today, we stabilize patients in the cath lab. We tell them, stabilize them in the cath lab. This is the best place. As you stabilize, we will block it because we can do a CT. We'll also talk about the future. In the next few months, we'll have India's first Nexaris. What are the Nexaris? We have a CT scanner on rails which comes into the cath lab, and the cath lab table becomes a CT table, and very, very useful in a patient who's unstable with trauma. We use the same data to embolize and stop bleeding. Then the recovery, the patient is stabilized, and then we allow the patient's systemic shock to subside, and then you do the definitive surgery. That is the right way to treat today, and anything other than that is history. You have a patient who's acidotic, who's in coagulopathy, who's in hypothermia, then you do a laparotomy and you kill the patient. Imagine at this point you intervene with the interventional radiologist, plug the leak, you reverse everything. The hypothermia can be set right, the coagulopathy can be set right, his acidosis can be set right. Now go and operate, do the definitive surgery. You have a live functional patient at the end of it. And I'll show you examples. This was exactly 30 years ago, right? Somebody said, as the first person to start IR, I'm not boasting, as one of the first person to probably in this part of the country. It's amazing. Patients will travel all the way from Kerala and Karnataka for somebody to save lives because they were bleeding after maybe a PCNL. Now, for example, this was a patient here exactly 30 years back in 1996. This is a patient they could not hemodynamically stabilize. The abdominal girth was increasing. The orthopedist refused to hand over the patient to me, saying he did not believe in this. A point came when nobody had anything to offer, and I said, please allow me, I'll treat it free of cost. It took me 20 minutes to plug the ruptured internal iliac artery. This guy is alive today. Because of what? Because of one simple, small procedure which involved blocking the internal iliac artery. But that would change everything in a hospital. People started believing, and today we get calls throughout the day, 24/7, where is a patient? We took away the decision for a surgeon to take. We said the ICU doctor takes it because we're losing time. They may be in the theater if they had to come and see. But now we find that we can turn around a lot of patients. For example, take a look at this patient. He's a 19-year-old construction worker. He was brought to the hospital hemodynamically unstable after a fall from the 3rd floor. Systolic pressure 60, diastolic not recordable. He was resuscitated, meaning, and sent to CT, means comes from the emergency. It doesn't go anywhere. Have a look at this picture. You got active bleeding coming from all over the place. This is the liver that's leaking. This is the spleen that is bleeding. Come down a little more. I'll show you where else is bleeding. You can see active bleeding in the region of the ileocolic fossa, and you can get a rapid hematoma that is coming out here in the lower lumbar region. Tell me, as a surgeon, what would you approach first? Where would you go? For us, it took 45 minutes. Each one of these. Either the patient is still not anesthetized, he's not even intubated. As they resuscitate, we just go inside, put some gel foam here. Then we come into the splenic, put some coils here. Then we come, you can see the ruptured artery. Can you see that? This is actively bleeding. We go there and put some coils. And do you know why these coils are floating like this? They are floating totally free in the abdominal cavity. We come from the other vessel on the opposite side. You can see there is an open vessel out there. We put a coil into this, and we go into the superficial circumflex iliac artery, block that, and the procedure time was 40 minutes. BP and then end of the procedure, 110/70 on no support. Surgery was performed next day when the CT showed the evidence of a contusion of the bowel. This is what you can do. This is what you can do right at Salem because of people like Karthikeyan. It is not difficult. Which surgeon today will say, no, I would like to go up to open up and do what? Handle the ruptured liver or the spleen or the bleeding iliac artery? They will die. This guy went home alive, totally alive, because this is precise, this is accurate, this is the way you should approach trauma. What about something like intercostal artery injury? Do you know this one of the worst things to take up for surgery? You'll never locate the bleeder, first of all. They will bleed and they will die. And they all should come for interventional radiology. A 60-year-old male, RTA, BP 110/18 or noradrenaline 6 ml per hour, heart rate is like 68. And this is the most difficult location for a surgeon to locate the bleeder coming from the posterior intercostal artery. Active extravasation over here. These procedures take like 20 minutes for us to do. Can you see the active bleeding out here? This is torrential bleeding because we are picking up straight on angio. How much time does it take? Nothing. Go inside, inject a drop of glue, and you cure this patient. Have a look at it. It's done. The patient is fine, and he settles down immediately on the table. We can take off the ionotop right by the time we stop the procedure in the next 20 minutes. Look at this. This is a post-stab injury. This guy is a transgender, had a fight with somebody, cut through the internal mammary artery. Which surgeon can seriously solve this problem? He would have bled to death. It's nothing at all. The CT shows the finding. You can see the artery, severe spasm because of the inotropic support or the hypotension that's going on, active bleeding going there. Enter that. The best thing out here is to put a little glue because the vessel is in spasm. You can't even size a coil. But the bottom line is a 30-minute procedure like this will completely transform his life and save this patient. Let's come to something like this. Traumatic aortic injury. Grade 1 and 2, you just need observation and follow-up CT. Grade 3, when there's a contour abnormality, needs an emergency treatment. And grade 4 usually will not survive. Even today, we keep telling ER, please make sure for every RTA where the thorax has been injured, do a CTA, because if you miss it, the fellow will die in the cath lab. Look at this. Outer. Can you see that? It's a miracle he's alive. How much time will this take? 45 minutes. And you can save lives over and over again thanks to the amazing devices that is revolutionary in the movement of aortic injury. Let's now move on from trauma to tumors. In tumors, when you work in a hospital, you can transform inoperable tumors and make them operable. If you discuss with them, they can tell you how it can be so safe to treat them. For example, here is a meningioma in a 30-year-old patient that is hypervascular. It's so vascular that the surgeon would find it extremely difficult, almost like a sarcoma. What exactly did he do for this patient? We go inside the meningeal artery, the middle meningeal. The ECA is supplying, but I'll show you how we can even take care of this. This is another branch coming. The management plan, we took a microcatheter and did a procedure which is called a pressure cooker technique, where we proximally block it and push a very diluted liquid embolic material inside. Can you see how the embolic material will finally spread? We could take the whole tumor off. The advantage, the surgeon finally is able to do a total bloodless surgery. Nothing, not a single transfusion, a live patient at the end of it, because you work as a team together, and the value that an interventional radiologist can bring to your hospital, you can do a near impossible surgery and make it possible because somebody made it totally safe for you to go ahead and operate. Here's another case, a very vascular mass that is there in the thorax. It's got a single vessel that is coming from here, so easy to treat for an IR, not at all challenging. A very simple procedure where he enters the catheter, takes a micro here and blocks it. And this is exactly what is done. And we are talking about these we did in 2004. We're 26 today, like 22 years back. And we are talking that this, if you think is modern, you can imagine how outdated you are. 2 decades before, we were doing such things and allowing people to have safe surgery. Also remember RF. RF is no longer just a joke. These are procedures that can transform the way an onco group works. It's an RCC, which you can just treat and you can burn. But you're going to use it as a team effort too. For example, let's look at liver tumors. Today, if you call yourself any hepatobiliary center that's worthy of respect, then you should be able to do sections that most centers would otherwise refuse. For example, take a look at these. When you've got a large tumor, how would you increase the functional liver so that the patient can survive and you can do excellent surgery at the end of it? So here is a 72-year-old male present with right upper quadrant pain, vomiting, hypotension present, started on inotropes or whatever. And here we go inside. we do a TACE, which stops the bleeding, also stop the growth of the tumor, and later we do a follow-up, and we convert this patient for a patient that can be taken up for a right hepatectomy, and the functional liver volume is inadequate. So we plan to do something called portal vein embolization and hepatic vein embolization together. So this is how it's done. They enter into the portal vein, the transplanic approach, you put glue and you block it completely. The end of the day, what's the advantage? The rest of the liver will will enlarge and hypertrophy. Along with that, we also block the hepatic vein. The combination is extraordinary with fabulous results. So if the liver was this, this is the same patient, you can see the size of the left lobe at this point of time, the large tumor out here. Following the embolization, you can see the dramatic shift that has taken place. This is after 4 weeks. We can see the left lobe has grown so much. And the end of the day, post-surgery, you can see how the rumor has completely been removed and you got sufficient tissue in the left lobe today to make sure that the patient doesn't die. This is team effort. This is something, the value addition in interventional radiology can bring to your life. If somebody says an interventional radiologist, an interfering radiologist, he's being foolish. He's not an interventional radiologist. He transforms your basic car to a Rolls Royce. You know, it's like I got this friend of mine. He runs a company called Kitab. He used to tell me, give me your car, sir. I'll just modify it and give it to you. It'll look like a Maybach, you know. It's something like that. If you want to drive and you want to be a fabulous center, then you need to understand these people can change the way you work. Look at that liver. Isn't that phenomenal? That is the kind of result an interventional radiologist can do for you and what he can do. Same thing can happen. You got a potential recipient. You're waiting. The patient got HCC. And you can go ahead and get a TACE or a tear or any of these things done to give you the time that you require and allow you to go ahead and do a transplant. So he's not taking away a job. He's actually improving the quality of your job and making you do work of international standards. The same thing happens in inoperable tumors in the biliary system, where he can palliate it by putting a stent for you and helping you, your patient, get better quality of life. Sometimes through that, we do brachytherapy also, allowing better quality of life and better longevity. Another place, again, partnering with them will change the way you work. You can also extend the window for life-saving organ transplants. This is for a patient as he's waiting for recipient. You know that today Rajesh gave this fabulous talk to make you understand TIPS is a life-changing form of treatment. It gives such good quality of life in patients who are waiting for transplant, in bleeding that you're finding difficult to control. And for TIPS, that's the only long-term way that patients can go on and on and on. Much, much better than what we ever imagined, right? But I'm going to talk, if you run a liver transplant program, how important it is for you to have an interventional radiologist on board. Today, no self-respecting transplant center can imagine having one without an IR on board. For example, this hepatic artery thrombosis. You've done a procedure, the patient's hepatic artery is thrombosed. An interventional radiologist can go there, do a thrombectomy, do an angioplasty, clear the vessel, and give back a liver which would have otherwise died. Or for example, in hepatic artery stenosis, where another case, very similar, you can see the tight stenosis out here and how you can open up, angioplasty it, and actually get back flow in this patient. You can see, or for example, in a patient with a splenic artery steal syndrome, because of a large spleen, which is actually drawing the blood into its circulation, and the liver is not getting enough, where you get a kind of an ischemia because of a steal phenomenon, you can plug the splenic artery and change the flow. And all these are cases by which you can allow a transplant to survive for many, many more years than we would have survived had it not been for you. Or another patient where the patient is covered with a very tight stenosis in the portal vein at the point of the anastomosis, where you can go transplant and fix it. None of these are possible surgically or could be disastrous surgically, and each one of this is something that you can do, or a biliary stricture in a transplant patient that has been fixed up. Okay? So let's move on further. Even now, if you still feel that these guys are the competitors and the interfering radiologists, let me show you where they are your safety net, where they can bail you out in some of the craziest kind of situation. Look at this. We get so many of these. Post-renal biopsy, post-PCNL, the patient comes with hematuria, you got a pseudoaneurysm or an AV fistula there. These procedures hardly take 25 to 30 minutes. Take a microcatheter, put a single coil, and you solve the problem out. It's phenomenal. It's so simple that you cannot imagine. Most of the work is done by our residents in training because it is so easy and they do it so effortlessly once we are there to supervise them. But what about this? You've done a fabulous job of a Whipple. The patient comes with torrential bleeding a few days later, and what do you find? There is a blowout at the stump of the gastroduodenal artery. Which surgeon would like to go there and fix this up? Imagine the interventional radiologist is truly like your knight in shining armor. He can fix it up. All these procedures, believe me, does not take more than 30 to 45 minutes. Very, very simple. Very, very straightforward. I'm not showing you the complex ones here, just to make you understand. Without them, your life is miserable. And with them, you can transform. Look at this. This is a patient with a lap chole. And this is very old. I'm just trying to show you this. Whenever it's round, you remember, this is an era of image intensifiers. Patient came with torrential bleeding, referred from some center outside. For some reason, the cystic artery clip has failed. And here is the big pseudoaneurysm that's causing the bleeding. We put some coils before and after, and the patient is alive. Each one of these are examples where iatrogenic injuries can be sorted out. You know what this is? There's a pseudoaneurysm following a tonsillectomy. Anybody's got a solution from the surgical side? The disaster. Can you see that? It's a huge pseudoaneurysm out here. The treatment out here, basically the best treatment is to do a parent artery sacrifice. A simple procedure. Will not take more than 45 minutes. Done in the conscious state under local anesthesia, gives back life to a little boy who would have otherwise died. Let's just talk about vascular malformation. You want to do high quality vascular malformation work, you need an interventional radiologist. Look at this case. It's a case of a large AVM with massive shunting. We do a DSA. We know by looking at the size of these vessels, this has got some massive AV fistulas. So what do we do today? We can enter these fistulas. This is the microcatheter right within the fistula. You can see that right there. Anything can be reached today with the technology we have. And what do? We go inside, we inject contrast, then we put some glue and block it, and we reduce the flow rate. We send the patient for SRS because the patient is not bled, and then we find that this does not work. He comes back to us. We go ahead, go inside each of these feeders, and we block them with an agent called onyx or squid, basically the newer agent for embolization. At the end of the day, the final story is a patient that is totally cured. Have a look at this. You can work in tandem with the surgeon. You can make the surgery safer. You can work along with the radiotherapist. You can work all three together. But when we work together as a team, we can make the impossible possible. And that's what I'm trying to show. Look at this. It's a 30-year-old lady, pregnant. She's got an IUD. She's come in a shock. She's got a massive hemothorax out here. See that? The problem is she's got a ruptured a pulmonary AVM. Can you see that AVM out here? Most of the cases I'm showing you are cases that Karthi will do and are right here. And none of them are they're complex if you do not have an IR. If you have an IR, they're not difficult at all. And this is what's done. We enter them. We put these plugs. One plug you can see out here. There were multiple AVMs and another plug for this AVM here. And at the end of the day, we actually treat this patient and block all of them. And the patient survived. She came to meet me even a couple of months back to tell me that she's alive because of the procedure that we did. We can do something as crazy as this. This is a newborn child. The problem is the child was getting into severe hypoglycemia. The problem was the patient had the shunt connecting from the portal vein into the IVC. Right over here, can you see that? And this was a direct shunt, and for some reason, because of that, the patient was just not doing well at all. what did we do in this case? We went, under ultrasound guidance and the fluoroscopic room to demonstrate this fistula out here. It was much easier, we realized, to see this than injecting a lot of dye. You can see the plug that is placed, the combination of fluoro and this. And the end of the day, this is the final result. Sorry, you can just see this is the plug, this is the vessel that is closed, and this is the end result, So this is the way we went. We came to the portal vein, we put a plug, and we closed it, and we treated it. These look crazy, but actually when you do them, they're not that difficult. Once you plan it and we execute it well, you can do the most impossible procedure. Another place where you make the impossible possible is in the management of crazy, complex aneurysms, where you do something called the hybrid procedures. This is a procedure where the patient has actually got an aneurysm which is in the thoracoabdominal region. One can do a fenestrated procedure, but this is a patient of autoarthritis, a young lady, and we did not want something that will not last very long. A surgeon does a procedure for us where he has actually done a visceral bypass. He ties up all the branches, and he creates his conduit and gives it to the renals, the celiac axis, and the SMA. And then we just put one single tube graft from top to bottom. The fabulous procedure. The long-term results are phenomenal, and it lasts forever and ever. And the end of the day, this is the final picture. You can see the patient has come back for a follow-up. We're taking over the aneurysm completely, giving him a permanent cure, and giving him these bypasses that can work. We can also do it to a fenestrated approach. We do that more when patient beyond 60 or 65 years, but when they're younger, we still prefer to do this. So basically, what are we seeing? We deliver borderless vascular safety across the entire human body. From head to toe, interventional radiologist treats life-threatening aneurysms, vascular anomalies with unparalleled precision. By operating purely from within the body system, IR achieves a standard of patient safety that open surgery can simply never, ever match. It's not to hurt a surgeon out here, but this is reality. And the faster you realize it, it's better for the quality of work that your hospital will give you. And therefore, you need an interventional radiologist as a central axis for the trauma and emergency wing, for the surgical theaters for their complication, for palliative care with stenting and relief, for oncology center with ablative therapy, for the transplant world by becoming a bridge for them, and for the maternity group by doing their PPH management. And this is the truth. And this is the fact. If you want to call yourself a hospital that's truly multi-speciality, truly a super specialty, you need to have an IR working over here. And probably the greatest place where this multidisciplinary symphony would work is for stroke. And in stroke, we have something called code stroke. A dedicated ER team initiates the flawless coordination required for a patient arriving paralyzed. We run a phenomenal system, believe me. It is so good that from the angel, we get the diamond over that year for the last 6 years. But it needs a huge teamwork to make it happen. We can restore the blood flow, but we need a whole lot of people to support the critical care people who monitor the BP thresholds and keeps the edema down and tracks on this, and neurologists who modify drugs, surgeon on standby for emergency craniotomy, and a strict PP control. It's at so many of us working. But the bottom line, people walk back because of this. And this doesn't end with this. You need a whole group of people who do rehab for you. The whole hospital system works to get these people back home alive. When some people call, I'm a stroke center, they're not stroke center until you got a full-fledged team that works. And this is probably the pinnacle. I think trauma and stroke are the two pinnacles where IR can actually transform the way your hospital function. I just want to show you one example, the last example, to show you the peak level of how a teamwork can bring people home. This is a baby. You can see that, right? 4-day-old preterm neonat, 29 weeks and 5 days, weighs 1,000 grams. But remember, of which 30% of the weight is just fluid because the child is in severe respiratory distress, as in cardiac failure. Severe biventricular dysfunction, reverse of flow in the thoracic aorta, there's pericardial effusion, dilated and increased flow in SVC, a PEEP of 8, FiO2 of 50 to maintain saturation of 96. Will this baby survive? Right? Without IR, I can guarantee you they won't survive. The antenatal image shows a huge vascular sac in the posterior cranial fossa. The antenatal scan makes us understand we are treating with a dural sinus malformation. It is large, it's huge, it's causing failure, and we know this even at the time of birth. At birth, we confirm the findings. We find this big vascular sac that is there in the posterior cranial fossa. This child is taken up for MR. We understand the pathology. We understand the vascular supply much better. We got to work on a 1-year child. That means the maximum tolerance of contrast we have is 5 ml. So we try to make sure we have all the information that we want before we start. Okay? This is just to show you the final picture with a little bit of gadolinium, showing how the middle meningeal arteries are the vessel that need to tackle. These are grossly hypertrophied. This is the cause of the child's problem. So just to quickly show you the fetal flow, to understand we have to get through the 2 umbilical arteries, where one of them has to be cannulated by the neonatal for us. So here it is. This is how the catheter comes, and we go up into the brain. This is the angiogram. Have a look at this, these massive shunts. They are crazy, huge shunts. But each one of them can be tackled by entering them with microcatheters and gluing. This is it. We go into one of the pedicles. You can see the microcatheter here. And this is the gluing that is done. And we continue to glue to bring down a reduction of flow about 70%. We never, if 100%, you can have a reperfusion hemorrhage. This is the other side. Very similar picture. Again, the microcatheter inside and the glue over here and the treatment. Okay. And this is the final angiograms that shows we have reduced the flow significantly. What happened post-procedure? Reduced PEEP and FiO2 by 2nd day of the procedure. Mild ventricular dysfunction, reduced reversal of thoracic outflow on day 3, 60 to 70% sac thrombus on day 3, extubate on day 5, and gradually weaned out. And this is the follow-up picture that we did, where everything has regressed in the child 2 months. And this is how this baby looked on the time of discharge. Can you believe it? This is that kid you saw, nearly dead. Making the impossible possible is truly possible when you have a good IR on board. And this is the child when he came for follow-up a few months later to me. This is a miracle. And I want to end up with this. You want to call your hospital a state-of-the-art hospital. You need an IR on board. Just having an IR on board doesn't make a difference. The hospital should understand they are an integral part of your system. You got to buy them the right equipment. They need equipment. It's like driving a car with headlights or without headlights. It's the role of the management to say, I want to do something great, get them a biplane. Sitting at Salem, gets this, get Karthi a biplane. It will change everything for you. For doing something like this, when you want 3 ml of contrast, how can you do it with a single plane system? You got to you double the dose, right? You make things much safer. Encourage autonomy. Allow the interventional radiologist to operate an autonomous clinical practice within the institution. The greatest example we have for that is what our breast center does. The breast center is run by a radiologist. What does she do? Every breast case comes to her. How does it work? When she gets a fibroadenoma, they don't go for surgery. All of them go for a minimally invasive procedure called VAB, which removes them out. If it went to the general clinic, they all would have left scars behind. Young unmarried girls, 3-4 lumps, 3 scars on the breast. Nobody will marry them in India, saying that you hit them, they were having cancer. What I'm trying to tell you is the truth. Give them autonomy. Make sure that when a fibroid comes, they come straight to the interventional radiologist too. No gynecologist refers fibroids except if they're a gynecologist themselves. How many prostates do you refer for intervention? You don't send them. You don't want them to know about it. But do you know it's the greatest procedure created on earth for the prostate? Why should he put them on alpha blockers? Why should he have reverse ejaculation? Why should he have incontinence? We got a simple procedure taking 45 minutes that can shrink the fibroid completely just because you don't want to tell him. Give them autonomy. Get them to be the first people to see patients, and the quality of life of your patient and the quality of your hospital will transform completely. Equip for excellence. Do you know we are setting up a cath lab that's going to be one of the best in the world? It's multiple labs integrated together. Why are we doing it? Because we know today that can change the way we work. One of the things that's going to happen is we got a CT scanner on rails that moves into the cath lab, right? And it moves back. We're putting systems in place to make efficiency so much that less people will die. And if they live with less morbidity. Elevate the standard. Together, this investment drives exponential improvement in the overarching quality of your hospital's care. It doesn't matter where you are. Your team has already proven to you that they can do so much today with a single plane. Imagine how much more they can do with a biplane. So once again, Karthi, I congratulate you and Santosh for the excellent work you have done, for the kind of transformation you have done, for stroke patients that do not have to move all the way to Coimbatore to walk back again, where time is life in all of them, for bleeders that you have saved. And I celebrate your success, and I hope this hospital understand interventional radiology is not experimental. It's not a joke. It's a lifeline that can transform your hospital and transform it for making the impossible possible. Thank you so much.
Thank you, sir, for that wonderful keynote address. May I now request Managing Director of Dharan Hospital, Dr. Selvaraja sir, to hand over the memento to esteemed Dr. Matthew Cherian sir. It was an honor to host you here, sir. Karthik, come. There is a saying in Tamil, Vasishthar Vayal Brahma Rishi. Thank you. May I now request Dr. Selvaraja to hand over the mementos to the moderators also. We thank all the three moderators to sparing their time on this Sunday.
May I request Dr. Periykarappan, our state president, and Dr. Pritham, state secretary, to join the stage. I request Dr. Santosh and Dr. Deepak to join the stage. Request Dr. Pritham and Dr. Periykarappan sir to address the session with few words.
First at the outset, good morning. At the outset, I would like to thank Karthik, Santosh for giving this opportunity. It's a wonderful venue. They have on a Sunday, on a weekend, they made good crowd to come over here. On behalf of the state ISVR, it's a good. Initially, we were conducting the meetings at Chennai level. We want to spread the awareness of intervention radiology across different parts of the state. Regarding how many of you are medical graduates over here? MBBS students, anybody? Postgraduates, radiology postgraduates? Okay, good number of radiology postgraduates. This intervention radiology is one sub-branch of radiology, which is rapidly evolving. As to the previous one of our mentor, Dr. Matthew sir's speech, if you would have listened, it's a cornerstone in any branch of any hospitals to develop, to move ahead in this. So that for radiologists who are already into post-graduation, it is getting subspecialized. You can choose this intervention radiology In intervention radiology also, it is getting more super specialized, like a neuro intervention, onco intervention, vascular, hepatobiliary. You can choose your area of interest, your passion. It will help you move forward. The only thing you get connected to the patient. We choose medicine to get connected and treat the patient better, improvement for the end customers. So when doing radiology, we would have lost touch with the patient. This is one branch we get connected with the patient. We have to work as a teamwork. As the concept of this meeting itself, it's association with the gastro. All branch like intervention radiology, though it is a sub branch, we have to integrate with other departments. We have to be maybe masters in all areas, starting from head to foot. We have to interact with neurosurgeons, neurologists, pulmonologists, gastroenterologists. You just select your area of interest into it so that you can focus on it and you can move forward. There is a huge gap in this, particularly in metro cities. Many interventions are there, like in tier 2 and tier 3 cities, big lacuna is there. The main concept of ISVR is to create awareness among the medical community as well as to the radiologists to develop this branch. As sir told, for stroke or any bleeders, rather than traveling, even though expressways, everything has developed for a patient, each second is lost, each second a neuron is lost. So by the way, if they want to travel from Salem to Coimbatore, it takes minimum 2 hours, 2.5 hours. So if it could be done over here itself, it would be a big boon for the local population over here. The cost, everything would be compared to the metro or other cities, it will be much cheaper. So the logistics, everything will be much better. So the main motto to develop this branch in all areas, in all parts of the states, particularly in Tamil Nadu, in Coimbatore, as sir said, many biplanes are available. We need a marketing person like a Matthew sir, whenever an hospital is started, to market ourselves, to project. Whenever some corporate hospitals, when they give a biplane, they ask for a return of investment. How much you can generate, how many cases you can do in a month to generate. In few corporates which I had worked, they don't have a 3D, everything. With a basic, with a single plane, we need to work. Once you reach that number, you can ask for a biplane. If you have a good volume, you can ask for a biplane. Otherwise, even in a small stroke, you need not expect for a top-end machine to do it. Even a small single plane send is enough to do stroke and aneurysms. All basic interventions, 80 to 90% could be addressed. This is one area maybe because we don't have the facility, we should not refer the patient. These facilities are enough to address, to save the life of the patient, which could be useful for the end customers. As one another important which I took from Salem is they work as a team. Like Karthik and Santosh, they work as a team rather than 2 eyes and 2 hands. With 4 eyes and 4 hands, you would be much better. Your stress level also would be much better, so that the patient gets the best benefit whenever we can take time off to spend time with the family. That is also a good concept. Thank you for the organizing team for giving this opportunity for us to be over here. And thank you for all the delegates on a Sunday for reaching over here and reach safely for all the faculties and delegates. Thank you.
I request Dr. Preetham to say some few words.
Yeah, can you all clap for Karthik and Santosh first for wonderful organization here? Thank you, Karthik and Santosh. You've done a wonderful job and having so much big crowd on a Sunday morning. Thank you everyone for coming here. For young radiologists or IRs who are starting, I'll just share my experience. When I started my career in a corporate hospital, everyone thought IR is some gimmick and it's just new thing. They're doing something and going, nobody know what it is actually. So it was 3 a.m. at night. There was a patient who was intubated, hemoglobin of 3, massively bleeding. Patient comes to our ER. The ER, the physician asks the gastroenterologist, he said, patient is quite sick, try to shift the patient under surgical gastro. Surgical gastro got the call at night 3 a.m. He said, no, I cannot do anything. What surgery I will do? You refer the patient to medical gastro. So a lot of issues happening at night, 3 o'clock. Finally, ER physician admitted the patient under my care and called me, sir, nobody is taking this patient. I know something can be done for this patient. I read somewhere there is a procedure called embolization. Can you try to attempt it? I said, no, we are doing a lot of procedures like this. Why not attempt? We'll definitely do it. I took the patient to CT, found there is a massive ileocholic artery bleeder. Within 10 minutes to the cath lab, 20 minutes procedure done, patient survived. Next day morning, I saw the patient in the ICU recovering well. Day 2, patient is sitting in the room with a newspaper. So, and then there are a lot of takers for the patient. Many people then plan endoscopy. The patient was found out to be having a tuberculosis of the endocecal region. Patient had a very good course. So from that day, the hospital realized the importance of interventionology, and many patients are across the city and the region are now referred to us for this kind of problems. And I think and hope all the best for Karthik and Santosh and the entire team of Salem, that you will do more and more IR. Just have faith in you. The management will see the work, they will see the revenue getting generated. They will definitely support and invest in IR. I also wish you all the best. Thank you very much.
I'm very thank for coming all the way down. And now we have multiple IRs in multiple hospitals in Salem. So we have all these therapies now available in Salem. So make use of it so that our region also gets developed as far in any other bigger hospitals in the country. I request Dr. Santosh and Dr. Deepak to address the gathering with few words, and then we'll go for the session.
Thank you very much, everyone, for being assembled here. When this agenda was given to us a couple of months back, we were very reluctant actually. Karthik told, yes sir, we can do it, and with the help of Deepak sir, we made this possible. With all your support, I thank each and everyone. Thank you.
A very good morning. I thank everyone coming all the way from different parts of the Tamil Nadu here to this ISVR meet. Again, as sir told that when I started IR interventions in Salem in 2016, there was very few clinicians refer the cases to me, like very few non-vascular cases and few vascular cases. Now I can see the trend of increasing IR procedures, and more clinicians are aware of the procedures that are being done here in Salem. So thank you all.
Request Dr. Deepak to felicitate Dr. Perikarapan sir. I request Dr. Santosh to felicitate Dr. Preetham sir. We'll have one photo, sir.
Thank you, Pruvan. Every new specialty or subspecialty goes through this phase when they develop as an independent arm like this. And I'm very happy to see so many interventional radiologists on this forum. We'll move on to the next session. May now request the moderators to come on to the stage. Dr. Nirmal Nitin, medical gastroenterologist from Dharan Hospital, Salem. Dr. Satish, surgical gastroenterologist from Pranav Hospital, Salem. And Dr. Jagadishan, consultant interventional radiologist, GKNM Hospital, Coimbatore. The talk will be by Dr. Rajesh, senior consultant medical gastroenterologist from Salem Gokulam Hospital, on endoscopic management of gastric varices.
Good morning, everyone. I thank the organizers for giving me the opportunity. This is the first time I'm addressing in a radiological forum. Most of the time we call radiologists as a guest to our society. It's the first time I'm sitting in a forum like this. So coming to the endoscopic management of gastric varices, the next 15 minutes, we'll discuss about the gastric varices bleed. So why it matters, how it differs from the esophageal varices. So you all know the gastric varices is less common than esophageal varices, but more severe than the esophageal varices. They bleed, and it has a high transfusion requirement and high morbidity and mortality if we don't treat properly. So Sarin's classification is the common classification used for a gastric varices bleed. It can be classified into esophagogastric varices or isolated gastric varices. So if it is esophageal, if it is the esophageal varices, comes along the lesser curvature, it is called a OGV1, esophagogastric varices 1. If it goes to the gastric, there is a greater curvature, it is called OGV2. If it is only the isolated gastric varices, if it involves only fundus, it is the IGV1. It is the other side, it is the IGV2. Why this classification is important is this can be treated like esophageal varices, whereas this needs different treatment. And another thing is the highest risk of bleed and morbidity, mortality is high in here and here. So the initial assessment is already all discussed by the previous speakers. A, B, C, D, E. D stands for drugs, E for endoscopy, and after the restricted transfusion and vasopressors and antibiotics, we do endoscopy after resuscitation. That is within 12 hours of bleed. So identify the fundal varices and plan definite treatment. So what is the definite treatment of endoscopic therapy? There are three varieties of treatment. One is the variceal ligation or sclerotherapy, that is for OGV1, that is the varices along the lesser curvature of the stomach. The glue injection is the first line treatment for fundal varices. That may be OGV2, that is IGV1 and IGV2. If you have the facilities for US, guided coil with a glue will be more useful. We all know the anatomy. This is the left gastric vein supplying the OGV junction, and they drain through the esophageal and paraesophageal varices into SVC, whereas the fundal varices is supplied by the posterior gastric and the short gastric vessels, and they drain through the gastrorenal shunt into the left renal tract. So why the esophageal varices and the gastric varices differs is the gastric varices is a large one, the high flow rate, so it requires a different treatment. This is one of a patient presented with a bleed. You can see there is a current active spurter from the OGV1, the high lesser curvature varices, spurting varices. So it can be treated like a esophageal varices. We inject a sclerotherapy. It's a difficult place to put a band there. So we inject sodium tetradecyl sulfate. You can see the submucosal bulge. Then afterwards, you can apply a band. You can, same sitting, you can do a sclerotherapy and a banding. This is the OGV1. So coming to this, that is the isolated gastric varices. So this is a large fundal varices. So just say palpated the varices, you can see spurter, the active spurting from the fundal varices, where you have to do glue injection. It is cyanoacrylate glue. So 1 to 1.5 ml we inject depending upon the size of the varices at multiple sites. So I am injecting a 21 gauge needle, cyanoacrylate glue. After injection, you can see just withdraw the needle inside the catheter and keep the catheter for a few seconds. Then I palpate the varices. It is hard here. Hard means it is solidified the varices. Solidified varices, it's varice obliterated. But again, it started bleeding from the other side. I injected some more glue. I injected almost 4 ml of glue here. This is the third injection of glue. Then I removed the needle. You can see again it started bleeding. At the time I had exhausted of the glue. So what we did is we put a zinc stick in black mode tube. This is one way of temporarily arresting the bleed. So next day after 24 hours, we removed the tube and palpated see the varices here. So I palpated the varices. Here it is hard. That means obliterated varices here. But here it is soft. That means it is still there is a residual varices there. So I again injected the glue. So completely obliterated varices now. This is the patient at the time of discharge. Sometimes it is during active bleeding, the fundus is a dependent position. You can't see anything, only blood. So what to do? So this is a patient. So we did in a sitting position endoscopy. So you can all people are wearing the goggles. to protect the eyes. So you can see the visibility will be fundus visibility will be good in sitting position. We injected the glue. See, the fundus will be clearly visible. This is a simple technique. So it's not always easy. Sometimes this is a patient, esophageal where there is no bleed, referred as a bleed. First endoscopy was normal, no active bleeding. Here appears normal. Right? So I thought where it is coming from. It's obscure bleed or there is no bleeding from the esophageal varices, but see closely. Here, this is a sign of bleed. It's very close to OG junction. It's very important. The scope should be in a good position in retroflexion. So we injected glue here. So this is the site of bleed which was missed in the initial endoscopy. So it is not always possible to do an endoscopic therapy. Sometimes PS is more helpful. So this is a large varices. I can see the CT. So big varices OG junction. This is the endoscopic ultrasound. Big varices. The coil embolization of the fundal varices. So after coil, you can see it's complete obliteration of the varices. The X-ray. This is a large fundal varices. The isolated gastric varices. This is to show how we also do coiling, not only the radiologist. This is a large varices, fundal varices. It's 4 into 3 centimeter. This is a puncture with a 19 gauge needle. Once it's inside the varices, you can deploy the coil. The 50 millimeter coil. Usually it may require 1 to 4 coils. Usually 2 coils will suffice. The coil acts as a scaffolding over which the blood clots. Sometimes after that we inject some glue also. The second coil. So glue. So over that complete obliteration will occur. So coil, the glue most probably 1 or 2 ml is enough. With complete obliteration, there is no flow here. The follow-up endoscopy will show it's a completely filled varix. Follow-up endoscopy, it's almost nothing. So why to inject coil and the glue? Why not only a glue or only a coil? The two therapies complement each other. The coil acts as providing a scaffold within the varices. It slows the blood and the embolization is less and promotes the thrombosis. And so together they achieve the faster hemostasis. Previously we used lipiodol along with the glue. So nowadays we don't use lipiodol, only glue, because the undiluted cyanoacrylate glue, it is small liquids are glowing because it omit, that is the faster polymerization. If you inject, the guideline says the chance of bleed, is more, and that is strict guideline which